I'll see if, you know, and I don't even know if again,
thank you for letting me know.
Okay, let me see. Thank you.
How are you? I know, what is it going to be? I have no way to predict what you're going to say. But it's going to
Everybody, here we go, ready to play, good, get up for another one, stay right there. All right, and again, here we go, 1, 2, and 3, smiles, good, thank you.
Thank you.
You should be here. This is my colleague who's from Denmark. She's a midwife instructor. She's actually, she has a replay on all the births. The data set I always talk about. Speaking. I'm going to go Not the same.
Oh, is that one of them? Oh, nice. He's everywhere. He's everywhere. I know there's so much. Unfortunately, you have children, like everything, there's nice to meet you. No, yeah, exactly.
Good afternoon. We're going to get started. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School. And I want to welcome you to this year, which recognizes the 28th year of the Leadership and Faculty Development Program in our conference here at Harvard Medical School, and more than 20 years of our Minority Health Policy annual meeting. And today's topic, I'm happy to say, is about maternal fetal health. And it's a part of our Equity and Social Justice series here at the medical school, an opportunity to talk and learn about a very important topic. This series, this Equity and Social Justice series, includes lectures, dialogues, forums for members of our Harvard Medical School, our affiliated hospitals, our Longwood, and our greater Boston community. And it provides a context to the historical, current, and future states of equity and social justice in health and healthcare. And it engages and equips participants with tools around four major areas: history and context, culture and environment, disparities, and the fourth is leadership and skill development. So within this past year, under the leadership of Alden Landry, as well as from really guidance, assistance, help, holding everything up from members of my office. We've had programs on American Indian health policy, Asian American health, Black men in medicine, Black women in medicine, a documentary, Latino Health Forum, precision medicine, the public health charge, and a Veterans Day ceremony. So today, I am sure it's not going to be informative, but it's also going to raise some challenges around maternal health and also hopefully provide us some insights around interventions and solutions to those challenges. It's good to know where the problems lie, but it's even better to know what to do about them. Today's program is being led by Dr. Alden Landry, who's an assistant professor in emergency medicine at Beth Israel Deaconess Medical Center. He's an assistant dean in our Office for Diversity, Inclusion, Community Partnership, and he's an associate director and advisor in the Castle Society at Harvard Medical School. He's also now the director of Health Equity Education for the medical school. And like everything at Harvard, he's also the senior faculty in the Disparity Solutions Center and a founder and co-director of a nonprofit organization, Motivating Pathways. Many of you may also know of him in his role in leading the Tour for Diversity in Medicine, which is an effort to increase the number of underrepresented minorities in medicine, dentistry, and other biomedical careers. He's been recognized by his peers. He's received many, many awards. I was last at the Health Quality Forum, so I could see him in his leadership role there. And I could be adequately impressed because he did such a good job. He's a graduate of Prairie View and University of Alabama in medicine, emergency medicine at Beth Israel. He did a Commonwealth Fund Fellowship here and has an MPH from the Harvard School of Public Health. And with that, Dr. Alden Landry.
Good afternoon, everyone.
Good afternoon.
See, Joan knows the call and response. I won't make y'all repeat because I know she usually does it anyways. But I want to say thank you all for coming to another one of our Equity and Social Justice lecture series. As Dr. Reed mentioned, we've had a number of these topics over the year, really over the past 3 years. And we've really tried to listen to what's happening in our country, what's happening locally, what some of the concerns are from our students and our faculty, and then also things that we think are important that just are under-discussed in medical education overall. And that's how we've come up with our topics for these issues. And I'm very proud of the topics that we've hosted so far this year. Talking about Latino health and talking about Asian American health and talking about intersectionality when it comes to different groups and how they may be experiencing our healthcare system and the negative effects that they may experience based off of their race, their ethnicity, their country of origin, whatever it may be. These topics are continuing to evolve, and we look forward to having more of these discussions just to broaden the discussion around medical education and practice here in the Harvard community, but we also want to make sure that we're embracing the Boston community and the state and the region. And if you look at many of our topics and many of our speakers today, they're not just coming from our institution, but we looked outside to hear what's happening in our communities and how others are leading these conversations and helping us to drive forward around these discussions around health equity. Our topic today around maternal fetal health was something that was really generated, again, from our faculty and from current and past fellows as we talked about some of the issues relating to health disparities and outcomes when it comes to maternal fetal health. And I would say right now there's a lot of political will that's sort of being generated. Numerous candidates on the Democratic side have introduced bills and legislation or are having discussions around outcomes and health disparities and black-white differences that we're seeing with maternal fetal health. There's been a bill released both on the Senate side and in the House of Representatives side about addressing health disparities. So there's definitely the political will to have this discussion and to make the changes necessary. But I think this conference that we're having today is really about what interventions are being done, because we know that the disparities exist. So what interventions are being done, and what opportunities are there for us to be leaders as we try and address the changes that are so necessary. I'm really excited about today. I'm excited to learn and hear from our panelists. I think we have a great group of speakers that are going to be joining us. But first I want to introduce our keynote speaker. His bio is in the handout that you have, so I won't read it for the interest of time. But our keynote speaker is Dr. Eugene DeClercq. He's a professor of Community Health Services and Assistant Dean of the Doctoral Education at Boston University School of Public Health. He's a professor of obstetrics and gynecology also at Boston University School of Medicine. And when I asked Dr. DeClercq about why he's so interested about this topic and what brought him to the research that he does, He mentioned about his own children being born and the experiences that they had, and then also the importance of students asking questions and asking the why. And that's really led him to dive more and more into this topic and think about this on a deeper and more rich level. So with that, Dr. DeClercq, the podium is yours.
Thank you. It's a delight to be here. It's an honor to be here. What Alden didn't mention is when he asked about that, I said, after the birth of my children, I decided to become a childbirth educator. Taught Lamaze classes, only male in the country at the time, strange to be sure. And it was in those classes that it generated the work that I do now, because couples would ask questions and I didn't have answers. Over and over again I didn't have it. Pretty much like my regular teaching, but more pertinent to them and more immediately important to them. And that's what started it. One question after another, and you sort of get sucked into this issue, and I can't imagine an issue that's more compelling to deal with than childbirth, given the ramifications of it in terms of the long-term impacts on the lifespan, and as a researcher, the variation in questions you have to ask. You know, to study this, you have to be not just an obstetrician or a midwife. You have to be a sociologist, an anthropologist, an economist, a policy analyst. If you really want to understand that, that's before we get to health services research, right? So all of those things have to be understood to see where we're going to make change. Now what I'm going to talk about today is maternal mortality. And let me get into it, because I have till 4 o'clock this afternoon, I'm told, right? I can just keep going. As some people here know, I could keep going till 4 o'clock, right? And I'll have hundreds of slides for that, but I won't. Let me first acknowledge my colleagues in this, that all my research is a function of collaborations. And these are all the people I've published with over the course of my career. And some of them are in this room. And I think if we're going to solve problems, if we're going to address problems effectively, it's only through collaborations. And although about 20 of these people are obstetricians, and about 20 are midwives, and I think we have to keep moving across lines and listening to each other and valuing the different questions that colleagues from different backgrounds ask if we're going to try to address these difficulties. And so everything I say that you find controversial or questionable, it came from them. Things you find pithy and interesting, that's just me. Okay, simplest outline you'll ever see. Right? I posed 2 questions. We're going to deal with those. Why is maternal mortality worse than you think it is, and why is it better than you think it is right now? But first we have to clarify some definitions, because there's a lot of things that get thrown around talking about maternal mortality, and there's different definitions and they have different meanings for us. So these are the 3 official definitions that get used. Pregnancy-associated deaths is a time-bound figure. It only means the death of a woman for any reason between pregnancy and a year after pregnancy, right? It can be, she could be hit by lightning. It is essentially the denominator, the starting point for analyses around this. I'm on the Maternal Mortality Review Committee, and there's several members of that here too. And that's our starting point, right? The first question you have is, the state pulls up all of the deaths that could be relevant to you, right? And then the first determination is this pregnancy related or not? I'm going to argue that it's critically important that maternal mortality review committees spend a fair amount of time on just pregnancy-associated deaths that are not pregnancy-related, because I'm going to make the argument that we have a crisis arising not just in maternal mortality, but in death rates of women in general. And as a result of that, the place that gets looked at in any depth right now are maternal mortality review committees. Now, they may be doing it as a screening point to which they have to get to get the pregnancy-related ones, but this is really a critical area that needs additional attention. Then the differences between the next 2 are the differences between the United States and the rest of the world, essentially. Because the definitions are similar, but they involve different time frames. So the maternal mortality ratio, death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of duration of the pregnancy, from any cause related to or aggravated by the pregnancy. Pregnancy-related mortality ratio is essentially the same definition, only it's extended out to a year. And the difference is WHO relies most heavily on the maternal mortality ratio. The CDC publishes the pregnancy-related mortality ratio. And the reason that has any importance at all is simply the fact that it's become a hindrance in comparing the United States to the rest of the world, that we don't conform to the way the rest of the world does that. How we get to that point will be the subject at the beginning of this, and the beginning of why this is maybe worse than we think. This is the timeline. I think it's straightforward enough. The blue line and the green line represent the pregnancy-related and the pregnancy-associated. Again, they both go from 21 months, right, from the initiation of pregnancy, assuming a full gestation, out to a year afterwards. In the case of WHO's, beginning of pregnancy out to 42 days. And this is data from Massachusetts that shows the rates of the two, pregnancy-associated and maternal mortality. And in a sense, we never think of it that way, but the gap that you see between them is the area I've become increasingly interested in. The non-maternal mortality cases that still result in deaths of young women, right? That we need to be paying additional attention to. When the gap is small, that means almost all of the cases are pregnancy-related. So, why is it worse? The U.S. has a problem, and we don't even know how bad it is. And that's pretty bad for a highly developed country, a wealthy country like our own, to deal with. How does that happen? Well, this is the data we do have, going back to the 1950s, and you see it in 3 periods. In this first period, from the 50s to the early 80s, a substantial decline, an 89% decline in the maternal mortality ratio in the United States. Very heartening, very positive. Then we get through the period of the 80s and 90s, and it's pretty much flat. There's almost no change whatsoever through that period. Then we get the period from 97 to 2007 that's actually going up, which is not what we expect with mortality ratios. Right? The assumption of the mortality rates or ratios, depending on which measure it is, we expect them to continually go down because we're the United States. People, again, there's more money available, people should be healthier. There's no reason to expect rates like this should be going up at any point. The other thing that's a bit curious here, of course, is why the hell does it stop in 2007? Right? What happens there that we stop presenting a maternal mortality ratio for the country? And it's a classic example. Depending on the audience I'm talking to, some people see it as sort of a conspiracy that, you know, because we were doing poorly, they didn't want to put it out anymore, so that would, no. First rule of thumb is always, before you think conspiracy, think bureaucratic ineptitude. And in this case, it's good intentions gone wrong, as you'll see. Nobody's trying to hide anything. They were actually trying to improve the measure, and in the process of trying to improve the measure, it raised all kinds of other problems. It's also the impetus of me being involved in this. I've been giving talks on this for 20 years, and one of the things I do is compare the United States to other industrialized countries, and this is one of the charts I would always show, and I do this with neonatal mortality and perinatal mortality and such. And when I went to do it with maternal mortality, it looks kind of silly that the other countries continue to produce data, and we're sort of sitting there for the last decade with nothing available. So that got me interested in dealing with the question. And this is the last actual official report. This was the last time they actually reported a maternal mortality ratio. It's a 2007 death report. And there's that 12.7 that you see at that point. And they haven't reported one since. I was at a meeting in DC last week where the person responsible for death reporting overall said that they've resolved some of their problems and they anticipate they'll report a 2018 rate, which of course will happen in 2021 because it always takes several years. So we still have the most recent data we have right now is 2016. And so it is coming back. Now, this great mystery, what happened in the interim? Well, this is what happened. They wanted to improve case ascertainment. The idea was, how can we improve case ascertainment? And the fear was that they were missing cases during pregnancy. There were missing deaths that occurred during pregnancy. And the attempts to improve case ascertainment actually led to over-ascertainment and then concerns about the measure again. So, for those of you who don't do vital statistics for a living, and I'm shocked that you don't because it's so exciting, but about every 13 or 14 years, they do a revision, right? We don't have national data. We really don't have national data. We have state data that gets sent to the national and put together at the national level that way. But the feds don't control all of that. What we do have is agreements between the states, And the states will agree that of the birth data that we collect, of the death data that we collect, of the fetal death data that we collect, we will agree across the country to send these variables to the National Center for Health Statistics, National Vital Statistics Branch, who will then compile a national figure from all of that. And as you might imagine, as we progress, our knowledge progresses, science progresses, we want to improve that, right? And because there's like new variables that may come up, new issues that may come up that we want to understand better. And so roughly every 13 years, in 1975, in 1989, in 2003, they have national consensus efforts to try to figure out which variables are we going to use. Are we going to ask all states to agree to send in? So it was at this time they decided they were trying to improve the measure of maternal mortality through this. This is a pregnancy checkbox. It's that tiny little box that you can't possibly read. But this is what it looks like. And it basically says, I'll just go back for a second, it says if the female was deceived pregnant at the time of death or within the past year, then that's a check, that's part of their checkbox. The actual checkbox reads this way. If female and of reproductive age, which is defined very, very broadly, I want to be inclusive here, if female, not pregnant within the last year, so the death certifier is supposed to do a review and check the box or not check, or check the appropriate box in this. So that was the idea. How can we pick up those cases during pregnancy? Because their fear was they were losing that. Now there's a whole history of this. This doesn't just happen. In the 90s, early 2000s, they're looking at this question. Other countries are using something like the checkbox as well. So we're trying to improve this. But one of the difficulties was 16 states already had something like this, but they had widely varying measures of it. This is just something, these are examples of states that had it. They used time periods like out to 42 days. Others use the language out to 6 weeks, out to 3 months, out to 90 days, out to 12 months in the last year. So part of the effort was to standardize that measurement, so we'd have the same measure across all the states. Standard epi data geek stuff, right? The other was, well, what about the 35 states or so that didn't have anything? They will now do it. Now we'll have a standard measure. This is going to work out, right? Every time they do this revision, I've been involved in this a long time. I've been through the last 89 and 2003 revision. Every time they do it, it's going to be great because we're going to get all this new information we can then use on a population basis, right? That's what's so exciting, is having this for the entire country as a data tool that we can use to make better clinical decisions and make better policy decisions. Well, slight problem. When they make the changes in 75 and they make the change in 89, the states agree. What that essentially means is they print a new form, right? They print a new form that the states have to fill out. They have to do training to make sure people appropriately fill out the forms, but it's printing a new form. And then those forms get submitted to the feds and somebody has to file all of that. By 2003, we're in a different world, right? By 2003, it's electronic systems, which means reprogramming systems, which is a lot more expensive than printing a new form and doing training. So the states go to the feds and say, fine, you give us money to do the reprogramming necessary. And the people at NCHS say, sure, absolutely we will. And then they don't. And so the states respond very maturely by saying, oh, well, the heck with you then. We're not going to do it. And some do it and some don't. And what this represents is the accretion of states over time in doing it. You can see it's adding to it. It starts off with 4 states that agree to do it, that add the checkbox. Another 7, another 7, another 4. And by 2007, they're essentially a form of equipoise. Almost half the states are doing it, and half the states aren't doing it. And the problem that that raises is all of the preliminary work, and actually the work even before they added the checkbox showed, states with the checkbox were reporting higher rates than the states without. So now the people at National Vital Statistics System are worried because they don't feel like they have a national data system. They have half the states doing one thing, reporting higher rates, and the other half of the states reporting by the old system with lower rates. And you can't just combine all of that. And so that's when they stop reporting. And that's why they're going to start reporting again in the next 2 years, because they think they've at least resolved the issue. By 2017, all the states will have added the checkbox. We'll see. Other problems arose as a result of that. Just to be a little parochial about this and brag a little bit about it, it's nice to know that at least in Massachusetts, we were the last state in New England to have actually made the change. And when we made the change, we not only made the change late, we did it in the middle of a year, which further complicates the attempts of trying to do this. But to give credit where it's due, we did the same thing with the birth certificate. That change was 2003. We didn't make that change until 2011, and we did it in like February 20th of 2011. So you almost lose that data year because you have these mixed systems going on, right? When I talk to audiences from New England, they love that. All the people not from Massachusetts love to see Massachusetts do something worse than they do. Always look down at other states. The only state that looks down more is the state of California, and damn it, they did it in 2003, so they ride on this quite directly. Now, that led to the analysis. So I contacted my colleague, Mary McDermott. She's the one I do most of the work with over the years. And she was at National Center for Health Statistics for a couple of decades. And I said, can't we figure this out? If we go and use state data and model the state data, couldn't we come up with a national estimate? If we spent some time and really thoughtfully did this, maybe we could come up with a national estimate we could use to then once again compare the United States to other countries. That was our goal. And that resulted in this article that came out now almost 3 years ago. Do we come up with sexy titles or what? Disentangling trends from measurement issues. I mean, there's a grabber. It's going to get a lot of attention from the media. Turns out this got tons of attention from the media. And the reason it did was that little underlying piece. So when we do the analysis, what we do is we model what's the effect of adding the checkbox on a state's rate. And then from that model, it's a pretty simple model, but from that model we come up with a trend number for the state and then combine all of the states. But when we did this, we had two states that were problematic. One was California, because California wouldn't report its data out to 42 days. They only reported it out to a year. You couldn't break it out, so we couldn't use California in trying to do a national maternal mortality rate, which goes to 42 days. There was no way to separate that out. Big loss, 480,000 births in California, right? The second biggest state is Texas, and we decided not to use Texas for a different reason. In Texas, so what we find is when a state adds the checkbox, the correction factor is about 1.9, almost doubles their maternal mortality ratio. So huge impact from that, right? In Texas, they added the checkbox in 2006. It makes almost no difference in their rate. But then between 2010 and 2012, their rate, which was already high at about 18, doubles to 37 and stays up at that 37 rate. And our analysis of it was, it's a data problem. This is not, I mean, Marion had a wonderful line in there, something, short of catastrophic weather event or war, you would never see this. This doesn't happen. Double. You would double in Vermont because nobody actually lives in Vermont, so there's no births there. But Texas has 300,000 births a year, so that's a pretty stable rate, right? The two most stable rates would be in California and Texas because of their size. And so we said we're not going to include Texas in the national estimate. For data reasons, not anything else. But what we didn't anticipate was there had been an article published in New England Journal shortly before that looked at the closing of Planned Parenthood clinics in Texas and argued about the loss of services, right? So what happens is this. This is the biggest, I've been doing this stuff for 40 years, it's the biggest media coverage we've ever had on anything we've ever done in this. Why? Because two things, I think. One, CDC had been putting out a pregnancy-related mortality rate for years, and no one was paying attention to it. Everything we talked about in terms of an increase had been reported. It was there on the CDC website for a decade and a half. But the term pregnancy-related mortality just didn't resonate with people. Once we call it maternal mortality, and then we did that simply because we wanted to do the international comparison, that seemed to resonate. People seemed to pay attention to it far more than it had in the past. But the other piece was that Texas finding. Here's the quote. You wouldn't expect that kind of a jump. That's the jump we saw between 2010 and 2012. So what happens? This gets reported, people jump on the, media likes to jump on the big find, and they report the Texas finding, and we're doing interviews saying, all they're saying is the data is, they probably have a really serious data problem there in Texas. But this first gets picked up in Texas. whole series of articles in Texas about us, our rates are doubling, there's a crisis. Interestingly, Mary and I were just at this meeting last week, and somebody from Texas came up and said, thank you for publishing that. We said, we just said your data was bad. She said, yeah, but that got everybody talking in Texas, and they were about to close their maternal mortality review committee, and they sustained the maternal, just barely, by the way, but they sustained their review committee, partly as a result of concern about the rate. Even though, remember, all we're saying is, we got really bad data and we gotta worry about it. So this comes out in Texas. Then it gets picked up after not after, but in conjunction with the New England Journal article, and the national media picks up on it, because it fills a sort of liberal bias, right? What's that? Dumping on Texas. And so there's all these articles linking the closing of Planned Parenthood to this. New York Times does 3 different articles on it. An op-ed, Paul Krugman does an op-ed on it, the whole thing. It's a story after story after story after. What does that do? That justifies the rest of the media jumping on it, right? Once the Times does it, everybody else jumps on it. So you got all of these. Note the quote at the bottom. That's pretty much what they would always say, right? Well, the authors would not say that there was a direct relationship between the cuts and the rise of, and then they would just go off and say it was because of the cuts, right? I mean, look at, Krugman's article, States of Cruelty. They're implying direct links between the closing. We're not saying it didn't happen. We're not saying it did happen. Our data was certainly not granular enough to let us do that at all, and we never said that in all of this. But of course, in the times we live now, what does this result in? We get attacked in Texas. And a fact check says they were wrong saying this was it. We never said that, right? That never happened. I like the one about pro-abortion activists hiding behind the often undeserved cloak of credibility provided by a peer-reviewed journal made a concerted effort to mess with Texas. No, he didn't. I like Texas. Okay, I don't like it that much, but I like it. And we had no reason to go through all of that. And that's one of the challenges now, right? Everything is politicized. I mean, the Green Journal published a letter to the editor about our article. If you look at the journal, what the Green Journal says is it has to be published, I think it has to be submitted within like 60 days or 90 days of the publication of the piece. It can't be more than 500 words. This was submitted a year and a half afterwards. It was 2,000 words, and it was a think tank, a conservative think tank in Texas that was funded to do this whole reanalysis. We did a big response to it, but again, this is like fighting over stuff we shouldn't be fighting over. What we said was there's bad data. So then Texas went and did a study, and what they proved was they had bad data, that there was all kinds of misclassification. Why? Part of it is, the question becomes, well, who's certifying all of these things, right? I mean, maybe in the mass public there's an assumption that certification of death is like by autopsy, right? Because they see that on TV, and it's right. 8% of the cases get an autopsy. So, is it a physician? Probably. Is it a medical examiner? Maybe. In Texas, it can be a justice of the peace who certifies the death. So, when you have a system that's that loose, you're going to have problems in your data. That shouldn't be a shock to anybody. So, back to our findings. So did we create a more accurate representation of state ratios, or do we have an overestimation? And our feeling is, despite we really worked hard in the article, at the end of the day it was an overestimation. So then we went back to the question of the quality of the data and started looking at that. Luckily, a separate source of information now is the maternal mortality review committees. The CDC has invested a great deal of money, mostly from Merck, funding them, the Merck Foundation funding them to do this, to do studies with maternal mortality review committees. And this was just published a couple months ago. A study, a 4-state study from maternal mortality review committees of the accuracy of the checkbox. And what this simply shows is, in 72% of the cases, the woman was pregnant. 21% of the cases where the checkbox was checked, the mother wasn't pregnant, the woman wasn't pregnant. In 7%, there was no way to determine if the woman was pregnant. So, probably have some over-ascertainment here, right? There's a problem. Now you're saying, really, how could that happen that often? What's interesting is, we modeled, what would random error do here? What if there was a 1% random error in the checkbox? Simply because people are rushed, they're doing it, And the deal is this, once you put the check mark in that checkbox, it becomes a maternal death. Right? It trumps every other code that you have. Right? So, when you model that, it turns out that it kind of fits what's happening, that you're going to have numbers like this if you just had random error in doing it. So, the other thing that you find, and this is because of that rule about if the box is checked, it has to be a maternal death, a big increase in codes for less precise reasons. So, this is ICD-10 codes, ICD-9, ICD-10 codes, depending on timing. And there's a whole array of codes associated with death, right? There's a whole cluster in the same area. But 4 of them are these, 4 of the old codes are these. Other specified pregnancy-related conditions, other obstetric complications, other specified diseases and conditions, other obstetric death of unspecified cause. And what we found was most of the jump in the mortality rates were coming from the other codes, which you can imagine if there's a mistake made on checking the box, someone then has to put something in there, and it's going to be one of the mushier codes. Now, before you feel too comfortable about this and thinking, well, then we're doing fine, sorry. If you limit the analysis to just the really specific codes, our rate's still going up. So it doesn't get us off the hook. This is why I say, this is why we should be feeling worse. We're both, by accurate accounting, doing worse, and we don't know exactly how much worse we're doing in all of this. My grandmother always said, life isn't simple. The other side of this is, before we throw out the checkbox, this was from another study using careful reviews. And what they found was, without the pregnancy checkbox, roughly 50% of the pregnancy-related deaths that occurred during pregnancy, 11% of the deaths that occurred within 42 days of the end of pregnancy, and 8% of those that occurred between 43 days and a year would not have been identified. So what you get is a classic result when we try to adjust measures. We improve it on one side, we hinder things on the other side. That's how measurement evolves, right? The key is to be transparent about what you're doing, to get in there and try to fix it as soon as you can. And that's what started to happen in all of this. Now, there has been a way we can monitor maternal mortality over time, and that's CDC. And so while we have this whole national vital statistics system that seems to be failing us, CDC is sort of chugging away with their own entirely separate system called the Pregnancy-Related Mortality System. And you go to the website, well, let me summarize this. So if we take the vital statistics system out, because it's not producing anything for us now. They're working at it, but nothing is happening. We have 2 sources of reliable data on maternal mortality. And the most reliable one is the Pregnancy Mortality Surveillance System at CDC. This is the definition of it. I'm not going to go through and read it, but basically it involves states sending them their data. It has the added advantage that they ask the states to link the death data to the birth certificate, which gives them a number of other variables that they can use. They also do positive case identification. There's somebody at CDC who goes through newspaper reports of deaths to try to identify more cases. So they put all of that together. That's the good news. The downside is it's CDC's data. This is not a public data set. This is controlled by CDC. They don't share it. They don't always play well with others with their data, right? It's their data. So we're sort of beholden to them on when it comes out. It comes out when it comes out. It's not part of the regular reporting system. Thoughtlessly, it came out yesterday, after I had already done all my slides. And so I redid my slides, the slides I'm going to present you in a minute, last night to incorporate the new data that they presented, probably for Mother's Day. My guess is not to screw me up, although I'm wondering about that. But I think it's probably for Mother's Day because they got a big hit. It was New York Times front page today. The third one is this maternal mortality review information application, the tortured Maria acronym. That's the reporting. So they now have set up a system where they're asking the states that have maternal mortality review committees to agree to a common set of variables that they'll report to the central site in CDC. And a lot of the states, Massachusetts is one of them, have participated in that system and are continuing to participate in that system. And the hope is that's going to be much more finely tuned data because it's going to be the result of the careful examinations at the review committees. That's great. It's going to be slower because Now you have that extra layer, right? It takes us a while. We're still reviewing 2016 cases in Massachusetts. So it takes a while for all of this to catch up. But it will likely give us variables we wouldn't get any other way. So this is the PMSS system. This is the report that literally came out yesterday from them, updating their data. And this is that definition again. So these are the trends, using, I think, our best existing measure. And what you see is, this isn't subject to the check, pretty much not subject to the checkbox. What you see is a consistent and profound rise in the pregnancy-related mortality rate. Now again, remember this goes out to a year, so the maternal mortality rate will be slightly lower than that. The other thing they did with this that's really helpful is this. They started reporting on the timing of deaths, which was great. We've been writing them to say, you know, this is the way to get at policymakers, is to talk about timing. Right? Not just this qualm of deaths, because you're talking about a 21-month period, and a death in the second month of pregnancy versus a death 8 months after the baby is born is a very different event. And for the first time in their annual article, the one reference there, they reported it. And then in this new report that came out yesterday, they went into it very deeply, which is great. That's a bit of a game changer for the discussion around this. A couple things to note here. Maternal mortality ain't Downton Abbey. It isn't somebody dying during the middle of labor, right? That accounts for some of these. It accounts for 17%, and if you want to say it lingers on for, you know, a condition may linger and cause, you're talking about a third of the cases are at the time of birth, right at the time of birth. A third of the cases are during pregnancy, and a third are between 7 days and a year later. This revises our whole consideration of maternal mortality, I think. It should. Because it means it's not just a clinical problem. What's circled there is the clinical issue, right? Clearly clinical issue. And what we've seen, and I'll get to in a moment, is a strong clinical response. The clinical community is doing a great job of trying to deal with this. But this is a public health challenge as well. It's a massive public health challenge that we have to address. And the other piece is, by the way, just a side geeky data note, if you have this data and you know the timing and you know that 11.7% of the deaths were between 42 days and a year, take their data, take out the 11.7% and you have the maternal mortality ratio, right? This is just simple logic. So I asked the people at CDC, I said, so if I report that, because I want to report it accurately, I said, what if I report that? What if I start using that as a rough estimate? I'm not saying it's precise, it's a rough estimate. Can I do that, and would you be comfortable with it? And they basically said, we can't tell you to do that because it's not necessarily appropriate for you to do that. And so I started doing it. Because that gives us, this is the best data system we have, and we can adjust it accordingly. Not perfect, but adjust it. So if you do that, this is the maternal mortality ratio. It just brings all those numbers down slightly. But now we can compare it to other countries, right? They also reported, and this is the old data. I'm going to give you newer data on disparities. That's from the previous one. I realized I didn't get all the slides. If that earlier slide I used where I said I couldn't report anything, now I can, using that. And it's a depressing story, right? That we start out worse than other countries, comparable industrialized countries, and we go up and they go down. And so the difference between ourselves and similar countries, wealthy countries with a large number of births, for reliable comparison, the differences are getting greater, not smaller, over time. What about racial disparities? This is from the new data. These are the rates they reported yesterday, ratios they reported yesterday. For Hispanics, 11.4 per 100,000. Whites, 13 per 100,000. Asian Pacific Islander, 14.2. American Indian, Alaskan Native, 32.5. Black non-Hispanic, 42.8. Stunning differences by race, ethnicity. The other nice thing, and I suspect the reason they use 5 years is this is the first time I've seen them reported for indigenous people as well. And those rates are appalling as well. Now, these are the rates over time. Back when we report, and this only has black-white because when you go further back, they weren't reporting Hispanic, and they couldn't do that. Fine. And what you see is that looks like the disparities are decreasing a lot. They're actually not when you think of it as disparities because the base number for the whites is going down. So you're saying, could you give us a chart that just looked at disparities? Sure, here it is. This is the black-white disparity over time. It's consistently between 3 and 4 times higher for black mothers than it is for white mothers. I think that's important. And I think you see how striking it is when you put it in this context. This is the black-white disparity from maternal mortality. This is the black-white disparity for infant mortality. There's nothing to brag about with the disparity on infant mortality. It's disgusting. It's 2.5 times higher for black infants than it is for white infants. But it is consistently and profoundly higher in the case of maternal mortality than it is in the case of infant mortality. And I pose that question, I would pose it in a class, yeah, I'm going to rush through this a bit and simply give you the answer, at least my answer. And I'm up here, you're not, so I get to give this answer. We care more about babies than we do mothers. We've structured a system that cares more about babies than it does about mothers. And we've emphasized that over time. Now, if that's true, how bad are we at babies if you're going to have that kind of a disparity? But it's even worse in the case of mothers. So how do we do in international comparisons? If we now have a reasonably reliable measure to use, this is how we compare to all the other OECD countries. This is silly, because this includes the Andorras and San Marinos and Luxembourgs of the world that have nobody actually living there. There's no babies born, that kind of thing. So let's do a more reasonable comparison. Countries with at least 300,000 births, wealthy countries with at least 300,000 births. And if we do that, we compare them, then that's much fairer, and instead of being 35th or something, we're last. And decidedly last overall. But here's where the disparities piece comes in again, because one of the implications, I've been presenting this stuff for years, and there's 2 responses that I get back in a lot of cases from clinicians who are defensive about it. One is that we do a better job of identifying cases than other countries, that's why we're doing worse. I don't think so. I just spent half an hour telling you how bad we are. But the other piece of that is they'll argue, well, we're more diverse than those countries are. And that's what the real problem is. And it's sort of an implied thing. It's about those minority mothers, right? And we'd be doing fine if it wasn't for that. So, all right, let me give you your due. What if we just compared the rates for white mothers against all those other countries? Well, then, if we actually do that, instead of being last, we'd be last. And that's a really important consideration here, because it's both things, right? The disparities are profound and real, and we need to address those. But at the same time, there's systems issues here that are going on, and a presumably lower risk population is not doing well either. Okay, it gets a little worse. Let's look for a minute at women's death rates in general, because who doesn't want to look at that? It's a fun thing. This is from the death reports, the overall death reports. And the figure you see up there reports deaths, and what you see is female death rates over time consistently going down. But note the circled areas. In some of those cases now, they've started to go up. And it turns out the age groups that are going up are women of reproductive age. So I took the data and started pulling the data out to run it. And this is what you see. You see a pretty big jump in 2015 and 2016. And this is overall death rates by age. And the most profound increases are women 25 to 34, which in turn happens to be the largest birthing populations. About 58% of all the births in the United States are to women in those age groups. So I continue to do the analysis on them. Here are the overall death rates of females 25 to 34 by race ethnicity over time. And note what you see. Overall, the all increases about 23% over time. Who knows, who knew that our death rates were increasing that much? Some people were deep into it, but the general public has no sense of that at all, that overall death rates are increasing. When you break it down by race ethnicity, actually the death rates for black mothers are going up slower. Overall death, this isn't maternal mortality now, this is overall death rates, are going up much slower, but at a much higher base. Right? The rates are still significantly higher, but going up much more slowly. It's the rates for white women that are going up the fastest in all these groups, which leads to the great irony of this slide. This is one of the few times where disparities are actually going down. Now, they're not going down because of much we should be proud of. All want disparities to go down. A little bit in this case. If you go back to 2005, the death rates for black females have been going down. death rates for white females have been going up pretty rapidly, thereby decreasing the disparities. But that's not the way people usually think of how they want to decrease disparities, right? By raising white death rates. It's not usually the goal. If you look at causes of death, it sort of reaffirms that. And what jumps out in the upper right-hand corner is the big jump is in accidents, unintentional injuries. Now, that's not car accidents. It turns out most of those are coming from this category: poisoning and exposure to it's opioids, right? It's overdoses, right? But in here also is increases in intentional self-harm, homicide, chronic liver disease. These are public health problems, right? The clinical community is very much involved in public health, but the public health community itself needs to step up and get more involved. So, is anyone discussing these increases? And by the way, male rates are increasing as well, in the same age group. Male rates have jumped by 26% in that same time. Yeah, I was. We put this out a while ago. Neil Shah and I put this out a while ago, and like most of the research I put out, disappeared without a wake. But we really need to be talking about this. We need to talk about this in a general sense of these increases that are happening. State of Massachusetts this is from a state report on opioid deaths, for pregnancy-associated opioid deaths. And these are by time period. And note in the postpartum period, the surge in substance-related deaths. But think about how often we drop mothers from the system. So, I'm not going to read all of these, but these are the I'm going to post these slides if people are interested. I'll post them and give my stuff away. Why are things better? Now I have about 30 seconds to do the good news. Very much an academic talk. I have a whole minute. I just doubled my time. A couple things. All right, at least it dropped in this most recent year. Okay, I'm looking for a hope here somewhere. In the update, it actually dropped a little bit, and it's not that's random variation for the most part. But it didn't go up at the time that all the other death rates are going up. And I think maybe some of the efforts that are underway around clinical improvements are having an impact. What you see here, if you look at the numbers across the bottom, these are causes of death over time. And what you see is declines in hemorrhage, hypertensive infection, 2 types of embolisms, and anesthetic complications. In other words, in the areas controlled by clinicians, we're doing better. What's going up? Cardiomyopathy, cardiovascular conditions, vascular accidents, in conditions that are obviously related to clinical work, but often very much related to community work, they're going up. And other is going up as fast as almost anything, which encompasses mental health, violence, all the other issues. So, the clinical side, we're doing a really good job. I think the AIM program, the establishment of perinatal quality collaboratives, the work coming out of California, I hate to admit it, is great and helping profoundly with that. This is just an example. Okay. Oh, good. They just extended my time. She says I can go until 4 o'clock. This is from the California Toolkit on addressing it, and I applaud. Again, I'm on the OB faculty. I love my clinical colleagues. They're doing it. I think they're doing their part in this. I think the public health community needs to step up and get more engaged in all of this. And I keep going. My students know I hate pie charts. I say, this is frequency distribution. Don't do it. It's silly. It doesn't convey that much information. And I put that stupid pie chart on my wall now to argue for public health involvement in dealing with maternal mortality. Because so many of the deaths are out of the period we most associate. What the public health community has done around childbirth, for the most part, has said, we care about prenatal a little bit, we care about postpartum, and we'll leave the birth to the clinicians. Okay, if you're going to do that, then step up in the prenatal period and in the postpartum period to make sure we follow up. So, what other kinds of things? Who can handle this? I think the review committees can handle it. I think perinatal quality collaboratives can handle it in terms of pulling together that side of this process. This is just more information on those. Again, some of you were on this. I know, I'm on it. The review committees, most of the states now have them. If they don't, they feel guilty about it because there's so much attention to it. I monitor this stuff, and state after state at least have to have a debate about it in their state legislature because of the national bill that was passed that I'll talk about in a minute. So this is a great resource and really, really helpful. For example, this is out of the Georgia Maternal Mortality Review Report. This is one of the things that you work on from Maria. What were the factors that contributed to this death, this maternal death? Note, these aren't precise categories, understand, right? We struggle with these when we're on the committee. But 56% of patient and family, 9% systems of care, 7% facilities, 26% provided, 2% community. In other words, if only a third of all these pregnancy-related deaths involve provider or facility, what are we doing about the other 67%? How are we addressing those? We tend to do what we can do, right? We take the skills we have and we want to apply them to do good. That's why we're in this business. Public health people have to do their part. I think the clinical community has stepped in. There's still work to be done. There's still mistakes that are made, and that can be addressed. But this is a time to move beyond that. This came out of the maternal mortality review report yesterday. And it's way too dense. And I always tell my students, never put that much content on the slide. I would highly recommend you get the report. You can download it very easily from the NCHS website. But notice what they talk about. The kinds of things they talk about as contributing factors. Access to clinical care, unstable housing, lack of or inadequate transportation, obesity and chronic conditions, health facilities, limited experience with obstetric emergencies. That's been the big focus of late. Trying to address that. Lack of appropriate personnel, lack of guidelines. For patient and family, lack of understanding of warning signs. Non-adherence to advice. From the system's perspective, inadequate receipt of care. Lack of case coordination. We see that all the time. The biggest challenge we have, I think, when we're doing the mortality reviews is the cases, and these are the cases, I don't get the clinical cases, but the cases that arise where it's someone whose whole life has been struggling, right? That they died 7 months after they gave birth. That's after 12 years of addiction. And they may have gotten sober they made extraordinary, breathtaking efforts to change their lives during their pregnancy, protect their babies. And then, for completely understandable reasons, the Department of Children and Families will still take the baby away because their lives are pretty erratic, and the mother crashes and disappears. And the way we structured our system almost encourages that, because if she was on Medicaid, and she qualified for Medicaid only because she was pregnant, 60 days after that, the eligibility goes, and she's out of the system, and we've lost them to the system. And so when we're having these, and these guys are all here, when we're having this discussion, it's sort of like, they know I whine about this all the time. It's like, is it preventable? Well, geez, if we had like a real social system that took people in early and worked with people for their lives, and we took a life course approach, yes. In the conditions we have now, no. If we just look at it from the perspective of we have a contact with her when she's in the hospital, no. The other side is the policy challenge. Don't worry, this is it. We passed the Preventing Maternal Deaths Act of 2018. It wasn't easy to pass. I think it's really critical to understand. What it did was fund the development of, essentially fund the development of maternal mortality review committees, provide funding to states that want to develop AIM programs and maternal review committees, which is great. My training, my PhD is in political science. I did legislative analysis for decades. I think of it as a policy perspective. And there's two ways to look at this. Either this is the beginning of a wedge that gets driven, and the strategy is you get your foot in, and then you incrementally increase support. And that's what this has to be. Because the other thing that happens, especially with maternal and child health issues, is we're treated symbolically. This was $25 million. That's like couch change in the federal budget. And the fear I have is that if we don't consistently work on advocacy, what's going to happen is they're going to say, we dealt with that issue last year. We just passed something on that. We don't have to deal with anything else. That's what we have to deal with. So here are the policy responses. President Trump even signed it. You can see how excited he is at having signed the Maternal Death Act. It's a big moment for him. The bill on the right is, I think, the stronger way to go. This is Senator Booker's bill, and a whole bunch of other senators. People, as Alden noted, people are starting to get onto this. The value of this is it says we will extend Medicaid coverage out to a year instead of 60 days for pregnant women. How does that work? I love this chart. I use it all the time. There's going to be a study coming out in the next couple months that updates it, which will be great. But what does this say? Look at the teal line, the bottom line. That's the number of women who are uninsured. And this runs from before delivery to after delivery. What you see is, before they get pregnant, about 20%, this is pre-ACA, about 20% of mothers had no insurance. They get onto systems, mostly, almost perfectly Medicaid systems, right? They're not getting onto private insurance. And by the time they give birth, at that time, about 10% weren't insured. That's pretty stunning in itself, by the way. And that number has come way down after ACA. But then, within 2 months, it's back up to 20%. How does that happen? This is how it happened. This is the poverty level requirements. And the national average is, for a family of 3, if you make more than 138% of the poverty level, you don't qualify for Medicaid. But if a woman's pregnant, that figure goes up to 205%. So the median number for all the states is 138 and 205. And if you look at the New England states, most of them are right in there. Right? They're right, Maine, okay. But the rest of the states are right in there. But look what happened in some of the other states. Texas is fine, it's 203% if you're pregnant. If you're not, if you make more than 18% of the poverty level, in other words, more than a whopping $3,700 a year, you don't qualify for Medicaid anymore. You're out of the system. So I believe in the wedge. I believe in starting and then building on it. I think we have to push for legislation that they're not going to do everything. They're not going to, Medicare for all may not happen. In waiting for that to happen, we make the argument, given the concern with maternal mortality, that we move in and we say, look, 12% of the women are dying from 42 days out to a year. Shouldn't we cover them for a year? Shouldn't we at least go that far to protect them? And then maybe, given the interest of maternal mortality, that can be the next step, and then we try to build on that, a step at a time. That incremental approach is how legislation happens. It involves compromise. We hate compromise because we think we know everything, but that's what's going to happen. So, finally, why are things better? Hey, 5 years ago, who was talking about maternal mortality? This wasn't a discussion at all. I know, Fifi wasn't. But most people were not. There was not much discussion of that, and certainly not as a national issue. The clinical community has responded. I've talked about that. MMRCs are a big help and moving forward. And the public health community has started to deal with that, focusing more on social determinants than it has. I'm going to close with this. There is political will now. We usually don't have it. The media is thoroughly and totally engaged on this issue right now. ProPublica has done a spectacular series. It was their Pulitzer-type series. I think they thought they were going to get a Pulitzer. They got a finalist. They didn't get it. But on maternal mortality, I would highly recommend it to you. It's brilliantly done. This is the case of a CDC doctor in reproductive health who died. Really? She died after she had given birth. And the series documents in excruciating detail how all the cases that were missed. So, people want answers. What kind of answers? Since you asked, this is what I recommend. Using the MMRCs, I talked about that. Using linked data sets. See, Fifi, I told you I'd talk about linked data sets. Linked data sets to give you a bigger picture of what's happening to women over time. Listening to women about, if you want to have sustainable responses, you've got to listen to women. It can't be a bunch of policymakers, old white guy policymakers sitting around talking about what women need. You have to shut up and listen to women about what they need in doing this. And then get involved in advocacy efforts. In 3 days? March for Moms is in Washington. I would encourage people to get engaged in this and get engaged in efforts like that. If you want the slides, go to this website, birthbythenumbers.org. These are all the students who work with me on it, and over the years, they've all been helpful on it. And I post my stuff there. So if you're interested, go there. We're revising it. There's going to be a bunch of other resources that will be started adding to it soon. It's not a requirement that you have a dog to join the group. So if you're interested, let me know. This is all volunteer effort, and the students do a terrific job in dealing with it. Thank you. sections of the pie chart, and we discussed that some in the committees, not as much as we probably should, around those issues. I think you have to go to the cases, right, the actual cases to see how that happens. One of the things that occurs in these cases is there's a tendency to say, so the mantra now is nobody listens to black mothers, or people don't listen to black mothers. And I do these listening to mothers surveys, and yep, that's what we find too, all right, that's really a problem. But then there's a sort of suggestion, it was probably about class, it's really not about race. And that is a crock. That's not the case at all. And obviously it's an anecdote, but it's an incredibly powerful one. The most famous woman in the world, Serena Williams, is telling her clinicians, I have a clotting problem, you really need to make sure you monitor this and take care of it. And they don't. If they're not going to listen to her, are they going to listen to anybody? And so I think you're absolutely right. I don't disagree with you at all. I think we need better ways to pull that out. That's the kind of thing, there's no ICD-9 code for that, or ICD-10 code for that. And so you need more sensitive analyses to do it, and it's going to be the accumulation of cases, and actually just sitting down and listening to women talk about their experiences to really get that. But we just don't do that well. We don't, we're scientists, we don't do qualitative research that much. That's crazy. That's the only way we get to it.
Hi, I'm Quinn Metzger. I'm from a former fellow and from the Agency for Healthcare Research and Quality from HHS. And we have the HCUP data, which is the hospitalization and utilization data for all births that occur within hospitals, and we get it submitted through the states. And what we're doing right now is trying to analyze all of the variables having to do with the women, but also where they're being delivered. We want to look at the hospitals and the types of hospitals, and we can also actually look at zip codes, levels, data from the patient to the hospital. And so I'm just curious to hear your comments about how you think, as far as women who deliver in rural hospitals or there's access problems, if that would contribute to this as well. Because we have all of that data, and it's almost like we have so much data, we actually don't even know what to do with it.
So there's some evidence about higher rates for rural hospitals. And part of this is going to be a question of transfers as well, and how well the systems are to transfer from one site to another. And at the meeting I was at, there was a meeting at NIH around maternal mortality last week, and you get sucked into these conversations about reimbursement rates, and if there's a hospital going to delay on a referral because of a reimbursement issue. You need systems. You actually need systems where people talk to each other, and you do risk referrals that identify women much, much earlier in the process. I mean, the difficulty is this. We tend to look at the data we have, not the data we need. And so I use HCUP data. We look at hospitalizations because we have hospital data. My argument is a lot of this is happening outside the hospital, right? It's happening before women go in the hospital. It's happening after women have left the hospital. There's nothing wrong with the old quote from Goethe about we look where the light is. We do research with the data we have, essentially, and that's, I think, a difficulty. We have to change the questions we're asking to say not just the hospital. So you're absolutely right, and I agree, but I think we have to go beyond that, to use other forms of data collection to really understand how these problems are happening and why they're not being addressed.
Thanks.
Your panel's next, so.
Yeah, you're reading your own time here, but that's
I
fine.
know, but I have to raise this question, so thank you. Of course, that was a phenomenal talk. And Dr. Clark, my only question is about that difference in the disparities, the maternal mortality rate compared to the infant mortality rate. That just begs the question of if you were to add in, make that rate about perinatal loss, if you add in stillbirths, does that rate still then reach that 3 to 4 times compared to baseline? Or do you have that information?
Probably. We don't necessarily have the data for that, but yes, there are disparities in fetal death rates, obviously, as well, which would contribute to that disparity and make it a little bit closer. I don't think it would make all of that up, though.
I just think I love that slide because it does point to your last comment about saying we need to focus on women and health for women before they're pregnant, because I
That's a crazy idea.
Yeah.
Yeah.
Thank you.
All the things to do. Thank you.
Thank you, Doctor. Clark, for your wonderful presentation and pointing out all the flaws in my great state of Texas, where I am from. With that, I want to bring up Dr. Audra Meadows, who is going to be leading our next panel, who is also a fellow Texan. She is an instructor at Harvard Medical School. She is the Director of Practice Quality and Innovation in the ambulatory obstetrics practice for the Department of OB/GYN at Brigham and Women's Hospital. She is a Commonwealth Fellow alumni in 2008 and received her MPH from Harvard School of Public Health. And with that, Dr. Meadows.
Thank you. At this time, I'd like to invite up our panel to take a seat at the front as we go to the top. As you guys know, this panel, this topic is maternal-fetal health, but we're focusing in on the maternal piece, which is important. And I appreciate Dr. Clark's commentary to show the difference between the maternal mortality rates and that of the fetal and perinatal loss rates, which are important. So welcome to our panel discussion, which we will start to think about something that Joan Reed has really instilled in us when we were fellows, which is to start thinking about disparities and solutions. How are we going to address these inequities through policy? How do we then lead to measurable, demonstrable solutions to tackle these issues that are so great and really lead to what we call right now human health crisis? So with that said, I want to introduce our panel and that we've brought up to look at some systemic interventions of how we can address maternal fetal issues, but specifically looking at this maternal mortality rate and the issues related to maternal mortality. So welcoming to our discussion, we have Dr. Fifi Diop, who is not only our state of Massachusetts Director of the Office of Data Translation for DPH, but she's also an MCH powerhouse. Dr. Diop has been a practicing OB/GYN, serves as the State Maternal and Child Health Director and epidemiologist. Also is the director of the Massachusetts Pregnancy and to Early Life Longitudinal Project, which is a linked database system, very important to understand and learn because not all states have that system. In addition to that, Dr. Diop has her MPH and is a champion for public health. She has been our person who has conceived of our state perinatal quality collaborative, and what makes our quality collaborative different from other state perinatal quality collaboratives is we take a very strong life course approach by connecting the work that we're doing on the neonatal side to the maternal piece, to areas of intervention in public health such as early intervention and Head Start. And we have that because of the great foresight of Dr. Diop and all that she brings to us. I want to also let you know that not only is she a colleague and a friend, she's also a phenomenal dancer, so I enjoy attending conferences and meetings with Dr. Diop. She'll talk to you today a little bit about using public health data to inform clinical practice, and I'd like to bring up Dr. Diop.
Thank you, Dr. Meadows, for that wonderful introduction. I want to say that the worst thing that happens to me at conferences is to have to speak after Dr. DeClercq. He's stolen all my lines, you can see when I talk. But the worst part is he's a white man against a black woman. What type of equity is that? That's not fair. When it comes to talking about the intersection of public health and clinical practice, there is a lot to be said. And of course, I'm not going to have time in 10 minutes to do that. But I'd like to give a very brief but high-level overview of three things. One is perinatal regionalization, which Dr. DeClercq alluded to a little bit. The other one is maternal mortality review in the US. And then the third one is guidelines and circular letters that come out of the Department of Public Health. Because it's been saying that we have to do the work, you guys are doing your job. So with that, I want to start with perinatal regionalization. In Massachusetts, in 1985, we developed and implemented regulations for perinatal services to ensure that appropriate but also safe care is provided at appropriate locations. And since then, these guidelines have been updated twice, once in 2006 and more recently in 2017. The challenge with these guidelines is that they are primarily related to the care of the newborn, which he also mentioned. We care more about babies than we care for mothers. So currently in Massachusetts, there is no system that designates levels of care for pregnant women. At the national level, given in response to the increases in maternal morbidity and mortality in the past decades, ACOG and SMFM have developed and published maternal levels of guidelines in 2015. And these guidelines are designated to promote collaboration between maternal facilities and healthcare providers, with the goal that pregnant women will receive care at facilities that are appropriate for their risk. To support implementation of the guideline, the CDC developed the levels of care assessment tool known as LOCATE to allow states and jurisdictions in assessing not only maternal levels of care, but also neonatal levels of care in alignment with the national recommendations and guidelines from ACOG, SMFM, and the AAP, the Academy of Pediatrics, American Academy of Pediatrics. The proposed levels of care includes 4. One is basic care for level 1s, and then the second one is level 2, which would include level 1 and specialty services, and then level 3, which will include level 1s and 2, plus specialty services, and then the highest level, which is the regional perinatal healthcare centers, which will include all other levels but provide the highest level of specialized services. The goal being that when pregnant women at risk are seen, they are seen at facilities that are readily prepared to respond to the levels of specialized care, the needed level of specialized care, and by the same token, reducing maternal mortality and morbidity. Now, I want to talk a little bit about maternal mortality reviews. In Massachusetts, maternal death review is authorized under Mass General Law, Chapter 1111, Section 24A and B, and the goal is really to identify and review all pregnancy-associated death from any cause during pregnancy or up to 1 year following the end of pregnancy. And you heard the definitions of pregnancy-associated mortality from Ginger Clark. We're not going to go into that. But essentially, the goal is to gain insight into the factors that contribute to both maternal morbidity and mortality, and to inform strategies to reduce the incidence of this tragic event. And a lot of us in the room here are members of the Maternal Mortality Review Committee. In Massachusetts, we review all deaths. But before that, between 1941 and 1985, the Maternal Welfare Committee at the Mass Medical Society reviewed maternal death voluntarily reported by hospitals. The Department of Public Health sanctioned the process, but we were not involved. And in the late 80s, this process kind of waned for 2 reasons. One was medical liability concerns, and then the other one was perception that maternal mortality was no longer an issue. And Jean showed that in the data. At some point, we weren't even collecting the data anymore. So in the 1990s, the mass hospital regulations were adopted, and hospitals were now required to report maternal deaths within 45 days to the Department of Public Health. But only a few hospitals were in compliance. They were not reporting to us. And in 1997, there was a very high-profile death in a wealthy suburb in Newton, which was highly publicized by the media. And of course, anything that gets the media attention then gets the legislative attention and then everybody's attention. So at that point, the Maternal Mortality Review Committee was established by the Massachusetts Department of Public Health. And now hospitals were not only required to report to the Department of Public Health, but the Department of Public Health was chairing the committee, and we review, like I said, all pregnancy-associated deaths, make recommendations and strategies that we disseminate back to the providers. I thought I was impressed you with this slide to tell you that case identification was difficult, but I think Junior Clerk did a good job at telling you how complicated is it. Of course, we don't know all the pregnancy-related deaths. We don't know about all the pregnancy-associated deaths because, A, we don't know when a woman dies, we don't necessarily know if she's pregnant because our reporting system right now allows us to know if there was a fetal death event. In case of a fetal demise, at 20 weeks or greater, we know that. But anything that happens below 20 weeks is not reportable to the vital statistic. So we are missing a great deal of pregnancies, losses, and women who died while they had when they were pregnant at less than 20 weeks. But in order for us to pick up on that, we do some data linkages, and we conduct data linkages with our pregnancy to early life longitudinal data system to pick up on some of the data. And the added pregnancy checkbox, which Dr. Duclerc also mentioned in 2014, is also helping us identify some of these cases. Back in the days when we talked to the medical examiner about adding pregnancy tests to when women die, we were told that it was violating confidentiality, so we didn't do it. But with the new revision in 2014, the checkbox allows us to pick up on some, not all. We're still missing a great deal. Now, instead of just looking at pregnancy-related deaths, like Jean said, Massachusetts actually, it's a rare event. We've decided as a community to collectively look at pregnancy-associated, severe maternal morbidity, which are near-miss events, conditions for which women could have died but didn't. And our data indicated that starting in 1998, there is a really sharp increase in severe maternal morbidity. Regardless of how we calculate it, there are a number of definitions related to, including transfusion, excluding transfusion. The rates are going up. If women are not dying, they're sicker, they're getting sicker and sicker, and we see that in the data. As a result, and of course, when you look at it by race ethnicity, no surprise, big gap between white, black, and white. And in fact, in the latter years, the gaps between black and white are increasing. And these are some of the recommendations we made at the Department of Public Health. Each maternity hospital should have clinical guidelines and protocols for the recognition and management of maternal hemorrhage, including standard timing and criteria for implementation of massive transfusion protocols. The guidelines and the protocol should include procedures that effectively address the clinical risk and management of peripheral maternal hemorrhage. And then, as part of our quality improvement collaborative, we launched the QI project focusing on maternal hemorrhage with 28 hospitals, and then maternal hypertension with 10 hospitals. We provided quality improvement training to 18 hospitals to be able to make some progress related to severe maternal morbidity. And then here's the slide Dr. Duclerc showed. We've been monitoring pregnancy-associated death related to substance misuse. Again, alarming trends going just between 2005 and 2014 from 8% to 41%. The recommendations for these coming out of the department were to screen all pregnant women through interviews using a standard tool, at the beginning of pregnancy, at 28 weeks, and at the time she presents for delivery, and then developing training on mental health, maternal mental health for providers to demonstrate proficiency in screening and referring women, and a lot of work with the Mass Perinatal Quality Collaborative around toolkits and best practices. We've been also monitoring oral health. As you can see, we haven't made a lot of progress here, but the recommendations included adding oral health questions to our perinatal care recommendations in collaboration with Mass Health. And we published an oral health guidance for pregnancy in 2016. We are still working with providers around implementation, which has been very challenging. And we do issue circular letters when there are emerging trends. The last one we had was related to substance exposed newborn. We had several before that related to HIV or H1N1. That's part of what the department does. We share the data and then we come up with recommendations. And that's my last slide. This is the contact info for DP. Thank you.
Thank you, Dr. Job. Next, among our panel of experts, I'd like to introduce you to Dr. Rose Molina. Dr. Molina is Assistant Professor of Obstetric Gynecology and Reproductive Biology at Harvard Medical School and is a practicing OB at Beth Israel Deaconess Medical Center as well, primarily in the Dimmick Center in Roxbury. Dr. Molina completed her Global Women's Health Fellowship at Brigham and Women's Hospital and obtained her MPH here at the Harvard Chan School of Public Health as well. I have the pleasure of having worked with Dr. Molina as a resident when she trained at Brigham and Women's, and she was a powerhouse and a dynamic person there with a beautiful heart who's definitely zoned in on this need to focus in on what we can do as clinicians to improve care for women. And so she's going to give you a clinician's perspective about how we can begin to address bias and the impact of bias on care delivery. I do want to add that I'm introducing these personal anecdotes because it's important to know that this is really sobering statistics about the health of women and potentially our infants, especially for Black women. And it's nice to know that the people that are doing this work, that we're working closely together, that are colleagues and friends, also have really nice human sides about them that we enjoy. And so I'd like to say that Dr. Molina is an avid traveler and a foodie whose favorite destination is Italy because of the food. And so I'd like to bring Dr. Molina to talk a little bit more about some interventions that she believes would be really impactful for us to address impact of bias with clinicians in the healthcare system.
Dr. Meadows. I'm so excited to speak to you all today about some potential solutions, at least from a clinician's perspective. I have no disclosures. However, I do want to start with a few caveats. The following solutions that I'm going to discuss are not easy. They require heart and mind, time and effort, resources, commitment, and grit. Even though our panels today focus on system and community solutions, we need to acknowledge that racism exists at multiple levels: personal, interpersonal, institutional, and structural. And we need to define solutions to dismantle racism in all of these spaces. But my brief focus today will be on the clinical encounter and looking particularly around patients, providers, and their interactions. I also want to say up front that overall we have very limited data about effectiveness of solutions specific to maternal health inequities, which are differences that are systemic, avoidable, and unjust. As we talked about earlier today, there's a larger body of evidence around birth outcomes, but less specifically about maternal health, which likely signifies the structural deprioritization of women's health specifically. But the solutions that I present today are likely applicable to inequities across many medical fields. So I just want to start briefly at the story of how I came to this work. I grew up in San Diego on the busiest point of entry between two nations, in an interracial immigrant family, and my parents instilled in me from a very young age the value of learning other languages to connect with people, whether it's family, friends, or strangers. From a young age, I felt compelled to strive for equity in the global South when I realized the stark differences in the opportunities people are afforded just because they happen to be born 15 miles south of where I was born, a circumstance that we all have absolutely no control over. This led me to work with Partners in Health when I was a medical student here at Harvard Medical School, and it was my experience in supporting midwives in rural Chiapas that taught me what it really means to believe that all people are worthy of high-quality health care, no matter where they live, simply because their lives matter. So solution one is to apply a lens of health equity to daily clinical encounters. We need to see our patients, hear them, and validate their lived experiences. Our purpose as physicians is to create a safe space in our clinics to build trust with our patients by connecting with them through our shared humanity, while also recognizing the intersectionality of their own identities. We need to prioritize our communication with them, particularly in shared decision-making, and this means we must listen to understand and not always to respond. Recently, I met a 41-year-old in my clinic who had a recent miscarriage and wanted to talk to me about birth control options. In our short visit, she described how she feels othered in nearly every moment of every day as a recent immigrant who doesn't speak English. She said to me, "Doctora, no soy bruta," which means, "Doctor, I'm not dumb." She went on to describe how she feels the sting of discrimination every day in being treated as if she were dumb just because she does not speak English. She went on about how she pours out her time trying to navigate through life, and even just to find a doctor like myself who can speak to her in her own language. The solution lies in being humble, compassionate, and inquisitive about our patients who come from all walks of life. And I encourage that all of us ask our patients about their lives and just think for a moment what it may be like in their shoes. I'm proud to work at DMIC, a federally qualified community health center in Roxbury, where I'm able to screen for patients' daily needs and link them to appropriate resources, such as health leads. I'm also able to connect patients to the medical care that they need with wraparound services, such as warm handoffs to behavioral health providers or a referral to our detox unit on campus for someone who needs it. For our postpartum patients, one of the most important things I can do is to effectively transition their care to a primary care provider in the same building, especially those with elevated risk of cardiovascular disease and diabetes because of pregnancy complications. This is particularly important, as we saw earlier in the keynote, that cardiovascular disease is now a leading cause of pregnancy-related death, especially cardiomyopathy among Black women. At DMIC, we embrace new models of care that center women of color, such as group antenatal care that allows women to build social support as they experience pregnancy together. And most importantly, we must incorporate equity as a process and not just a process in our daily encounters and not just an outcome. Solution 2 is to recognize implicit bias and build accountability to mitigate it. With regard to maternal mortality, we have seen differences in preventable pregnancy-related deaths by race, which have also been paired with the poignant stories in the media, which call into question the role of bias. We need to recognize how implicit bias saturates all of our lived experiences and daily interactions. Yes, skin color is certainly an important one, as is obesity, appearance, age, gender, among others listed here. The good news is that research shows that doctors are no more biased than other human beings. The bad news is that doctors occupy a place of power and their biases can have important impacts on their patients' health. But the good news is that implicit bias is a habit that can be broken. We have to recognize that this is a lifelong journey for all of us. The goal is not necessarily to stamp out bias, but to be sensitive to it, name it, and hold each other accountable for mitigating it. This requires daily self-awareness, self-reflection, and transformation, and we need to role model this behavior for each other and for our students. It requires humility and a commitment to do better every day. In response to the outpouring of public stories of women of color who felt that their health care team did not listen to their concerns, this past weekend, ACOG, the American College of Obstetricians and Gynecologists, announced its public awareness campaign. I'm wearing the pin here. It says, "I'm listening, every mom, every time." Additionally, there are several bills at the state and federal levels about mandatory implicit bias trainings to address inequities in maternal morbidity and mortality, but they need to be more than a checkbox. We need to identify best practices and content for these trainings so that they actually have an impact on behavior change and patient outcomes. And then we need to identify how to scale those up. Solution 3 is to ensure diversity in the healthcare workforce. We need to build and support a diverse workforce that reflects the patients we serve. A recent study found that Black men seen by Black doctors receive more effective preventative care than those seen by non-Black doctors. And this effect seemed to be driven by better communication and more trust. The medical field is making strides in closing the gender gap, with 39% of full-time faculty being female, but only 4% of full-time faculty are females of color. In 2015, only 6% of all medical graduates were Black and 5% were Hispanic, yet 13% of the US population identifies as Black and 18% as Latinx or Hispanic. The need for a diverse workforce extends beyond just medical schools, but also to other health professional schools such as nursing, and the pipeline needs to begin early as middle school. Secondly, we need to center and support patients through interdisciplinary and culturally congruent care teams. As the result of the many stories of mistreatment during childbirth among women of color, as we mentioned, Serena Williams, and in the Lost Mother series, some women now are actually scared to deliver in hospitals and are seeking alternative birth options. This can, at some times, lead to strained relationships among the healthcare team, between lay midwives, professional midwives, doulas, obstetricians, and other healthcare providers. We need to change the narrative that sometimes depicts maternal health professionals as blaming each other for bad outcomes, and we need to move forward together as a truly integrated team, as shown here with the patient at the center, and surrounded by a team of providers with different levels of expertise. To that end, we need to recognize a just culture that essentially no one comes to work trying to harm people. And we also need to see that just like our patients, healthcare providers also function in a structural context that may constrain their behaviors. We are seeing an epidemic of physician burnout, as published by many of our colleagues right here at Harvard. Nearly 45% to half of OBGYNs nationally report symptoms consistent with burnout, and this is also true among midwives. We know that burnout is associated with major medical errors. This is not an excuse, it simply means that we need to find a system solution for the physician work environment in parallel. We in the United States can learn a lot from other countries regarding the positive impact of culturally congruent doulas and community health workers. Until our workforce reflects the patients we serve, we need patient advocates like them who can come from the same communities and help our patients navigate transitions between home and hospital and back home. Solution number 4 is to foster inclusion and belonging in the healthcare workforce. We need to build an inclusive environment to support and retain people of color in our workforce, and that may mean developing programs such as mentorship, coaching, and sponsorship that really allow the healthcare workforce to feel valued and supported in their work. John A. Powell is a professor of law and African American studies at UC Berkeley, and he argues that we need to go beyond inclusion to belonging, a radical idea that is much more than being seen and being included. He writes that belonging is not just how we treat each other, but it is how we actually organize our economy, our structures, our schools, our faiths, so that everyone belongs, and recognizing we still have differences. Lastly, solution 5 is to integrate health equity and advocacy training in undergraduate and graduate medical education. We need to teach the structural competency to understand the underlying power structures that shape the social determinants of health that we all know about. Structural competency has been defined as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases also represent the downstream implications of a number of upstream decisions about such matters as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definitions of illness and health. This graphic comes from the Boston Public Health Commission, which illustrates how racism is the driver of the variation in social determinants of health, which we all know impact health outcomes. We need to ensure diversity of clinical cases that do not perpetuate stereotypes, and we need to stop racializing illness and disease when we teach our medical students. We need to teach the history of racism in medicine to medical students and residents and acknowledge our profession's mistakes so that we can better understand the distrust patients have in our profession. For example, in my own profession, as an OBGYN, I had not heard the story of Marion Sims until I wasn't attending. He is considered one of the fathers of gynecology, and his name is commemorated on a retractor that gynecologists use on a daily basis. It was not until after I became an attending that I learned that he practiced surgical techniques to treat obstetric fistula on slaves without their consent and without anesthesia. This is his statue in New York City that was only taken down 1 year ago in April 2018, and the other statues commemorating him still exist. We need to teach our students about the history of redlining in Boston and the decades of the Federal Housing Authority's disinvestment and explicit racist policies that impact where people live and their health and well-being to this day. We need to tell the story of Henrietta Lacks, whose cervical cancer cells were taken from her without her consent and used to develop the most commonly used human cell line called HeLa cells. We also need to acknowledge that there were forced sterilization campaigns that occurred in the 1970s among the Mexican immigrant community. We should also teach about the history of social movements and contemporary frameworks that are relevant to the practice of medicine, such as obstetric violence, which originated in the human rights movement in Latin America, the White Ribbon Alliance, and reproductive justice. Lastly, we need to infuse advocacy training into medical schools and residencies by telling our patients' stories in the places of power and using our platform and status in society to speak out for what matters to our patients, such as expanding Medicaid and paid parental leave.
One thing she and I share in common is that this interest and love for the idea of group prenatal care, and so something that Dr. Grant worked on across the state of Georgia was implementation of centering pregnancy programs across the state and received an award for such. Importantly, her humanism in medicine is obvious, and the fact that she's invited here as a panelist, the work she's done, but also her humanism extends to really interesting pieces of art and her skill for antiquing. And so you can definitely have a conversation with her about that, the beautiful brooch that she brought with her today. But with no further ado, I'd like to bring up Dr. Grant.
Thank you, Audra, for that kind introduction. I am one of 2 MFMs and the director of the Regional Perinatal Center in Columbus, Georgia. And for those of you who aren't familiar with Columbus, Columbus is about an hour and a half south of Atlanta. The demographics are about 50-50 black, white, about 6% Hispanic, and about 2% Asian. We actually boast some of the worst perinatal outcomes in the state, and that was one of the reasons why I chose to go there. In fact, in the last 2.5 weeks, I have had personal experience with 2 maternal deaths. Let me just say that we are being in Georgia, and in South Georgia, we are located in the belt buckle of the stroke belt. It is very, very uncommon for us to see hypertensive emergencies. I can't tell you how many times just from my office I've actually sent patients, which my office is right across the street from the hospital, via ambulance because of blood pressures 215 over 115. It is so common to see just extremely high blood pressures that I think our physicians and our nurses on the hospital side are just desensitized. So I would be rounding, doing antepartum rounds, and just be stunned the next day by these just ridiculous blood pressures that went untreated during the night. And it just became so concerning to me that I took it to the executive OBGYN committee, which I am a member of, and I said, you know, we need to do something about, you know, this failure to treat. It's the standard of care to treat blood pressures of 160 over 110 or greater, and we're not following that standard. And you know, what is going on? And so to my surprise, I thought, because I was like, we need to be actually, and how do I advance this slide with this one? So that was our hospital. So I said, we need to be practicing in line with the Council on Patient Safety and Women's Health Care hypertension bundle, which is, you know, is evidence-based and endorsed by ACOG of treating these blood pressures that are consistently or persistently elevated 160 systolics over 110 diastolics, and why aren't we doing that? And to my surprise, I actually got pushback. And the pushback actually mostly came from nurses, the nursing directors and the nursing, and the concern was that, well, if our nurses, I was like, you know, part of this hypertensive bundle is notifying, a mandate to notify the physicians, and we aren't even consistently doing that part. The other part of that response is to treat within 30 to 60 minutes. So surely we're not doing that either if we're not, you know, consistently notifying. So some of the nurses on the committee said that, well, our nurses are not going to call these physicians at night because they're afraid. And they're afraid they're going to get yelled at, and they're afraid of this, and the doctors aren't going to treat anyway because these blood pressures are commonly seen, and so they're not going to, you know, the doctors aren't, you know, going to treat, and we don't really want our nurses being yelled at you know, by the doctors in the middle of the night. And I was just floored by this. I mean, I think my head was about to explode, and I'm a very sort of passionate person, and my voice started to get high-pitched, and I was like, well, all it's gonna take, I said, this is a quality and safety issue, and this committee is charged with that, and all it's gonna take is one 15-year-old that strokes out, and we won't have a leg to stand on as a hospital. So at that point, I think I got their attention, and so there was some agreement around the fact that it was, in fact, a quality and safety issue, and that we needed to promptly address the issue. So we basically sent out a letter to all of the practicing physicians, and we posted the letter on labor delivery, and we attached that to the recent ACOG committee opinion that came out in February about treating acute hypertension. And I think we have really gotten some good response. I'm no longer seeing, this issue as much as I was on antepartum rounds, and in fact, most recently in our executive committee, the nurses were actually bragging about one of the nurses that had to check one of the residents who had an outburst when the nurse called and said, don't call me about that blood pressure. I only want you to call me if the blood pressure is greater than 180, a systolic of 180. And I might add that the hospital has standing orders and have had those standing orders for quite some time, but a lot of the doctors had personalized their standing orders and had changed their standing orders to tell the nurses not to call them unless the blood pressure was over 180 systolic. So anyway, the nurse basically, put the resident in check, and the blood pressure was promptly treated. So, I say all of this about these, for most doctors really want to do the right thing and the best thing for their patients. And just by, giving them the guidance and putting it out there, the majority of people are going to fall in line with that. But there are always going to be some that's not, and for that reason, you do need a system-wide approach. And from my experience working in public health and now working in the hospital system, is that you have to identify a problem, you have to make that problem be understood as to why that's a problem and what the solutions are. And then you have to empower the people. The leadership has to do that part, that front end part. And then you have to empower the people, and in this case it was the nurses really, to speak up and to report. And then you have to have a committee that responds to it and monitors it and gives feedback about it. So I think that's just one example of what we've done at Piedmont Columbus Regional from a systems perspective. The other thing we've done is that a lot of our patients that are candidates for low-dose aspirin therapy, so one of these upstream solutions, low-dose aspirin therapy has been shown to decrease preeclampsia. And while it only decreases preeclampsia about 10 to 30% is all we basically have, but it has been shown to decrease the risk of severe preeclampsia or pregnancy-induced hypertension, resulting in preterm births less than 34 weeks of 60%. So what I found in my consultative practice is that a lot of our patients are coming to me well after the time where it would be most effective, and aspirin is most effective before 16 weeks. So we've done an outreach and similar outreach, sending the committee opinion, sending a letter to the physicians, and we are seeing some improvement. We've got a long way to go there. We don't have a systematic approach that we can deal with community physicians on that, but we are seeing some improvement. So again, I just wanted to close by saying that sometimes it does take these overarching system-wide changes to really kind of affect practices. Thank you.
Thank you, Jackie. That's very near and dear to our heart as well. So our state PQC is working similarly to implement guidelines related to the Council on Patient Safety and Women's Healthcare Safe Motherhood Initiative through AIM. So there are bundles of safety bundles called the Alliance for Innovation in Maternal Healthcare AIM bundles that our state is working on implementation. So I think that's really appropriate and important to discuss. I want to just quickly encapsulate some of the things we've heard today, just with our panel of obstetricians and gynecologists talking about systemic interventions to address this trend that we saw from Dr. DeClerc's slides on maternal mortality and the rising rates and disparity related to that. And so for those of you with an MPH background, who remembers the social ecological diagram that shows the interrelationship between starting at human, individual, human, out to the greater systems of your community, out to greater systems related to public policy, et cetera. And so with that said, it's important for us to think about where these interventions lie and the interrelationship between them. And so importantly, we're hearing about what we can talk about with our patients and how clinical providers can be selected, for lack of a better word, to engage with a provider that would be someone they can relate to through language, through an experience of feeling they belong in their healthcare system. We've also heard a little bit about how around that, within our hospital systems, there are evidence-based safety bundles that we can start to put in place to start this interplay of conversations and communication around patient care and standardizing and bringing quality to the way that we offer that care. And then greater than that, we also have these state policies and state activities that happen, like our maternal mortality review committees, the work on these maternal levels of care, so designating hospital designations. And then greater than that, we've got these areas related to public policy. And so you'd heard in Dr. Clark's slides, the policy that was passed related to funding maternal mortality review committees. But as you can see, there's 1 to 4 examples maybe in each of those areas, potentially 5. And with that, there's more to go and more activity for us to grow within. And so with that, I'd like to allow folks to stand up and bring some questions to our panelists, because this is an interesting area of multidisciplinary teaming that we can start to engage in across disciplines, across areas within public health, and across our diversity of thought, so that we can really start to tackle this problem. Because I don't see anyone standing up just yet, and we have some more time, I'd like to take the liberty to ask the first question. I think that what's really interesting here to hear about is something that Dr. Molina brought up, and I think interesting for our panel, so the 4 of us are all OBGYNs, and that is this, who is having the conversations. A lot of what's been in the media has actually focused in on other professionals related to obstetrics care, and those would be our doulas and our midwives, more so than our obstetricians. And I'd actually like to add that there seems to have been a little bit of a tension created between the 2 groups of practice in terms of having this conversation and how we can work together. One of them, from a recent conversation that was hosted at another university system during maternal mortality and maternal health week, came up when the person asked the question about why would somebody who had a maternal hemorrhage deliver again in a hospital? Why wouldn't you go to a birth center? Sort of creating this assumption that delivering in a hospital leads to these negative outcomes, and delivering in a birth center would lead to positive outcomes. I want to throw that toward you guys and hear your thoughts on care delivery and the types of facilities that women are allowed to have babies, and what you think about how that plays into that conversation between the groups of people that deliver obstetrical and prenatal care to women when they're pregnant.
I'm happy to maybe say a few comments about that. I certainly feel that tension a little bit, at least how some of the stories are being portrayed in the media, that there's this dichotomy or between hospitals and other options, whether it's community places, birth centers. And I think the important thing is a lot of the work around regionalization and maternal levels of care. So ACOG is doing a lot of work around defining what sort of risk stratification categories are appropriate for different levels of care. So an independent birth center being like a level 1 level of care up to like a tertiary or quaternary level of care. So I think it really needs to be individualized based on the woman's preferences and then what her potential risks for having a complication during childbirth really are. But I think it goes back to that relationship between whether it's a midwife and a patient or a obstetrician or a nurse practitioner. I think what really matters is that there's trust in that relationship and that these can be open conversations about what a woman's potential risks are, knowing that in obstetrics there's so much uncertainty and we cannot guarantee any particular outcome for any particular person. And so I think that we need to move the sort of narrative over into thinking about how can we engage patients in these conversations and talk about these risks that we are uncertain about and how to help them sort of navigate that decision making about where is most appropriate for them to give birth.
I've had the privilege to work with some excellent mid-levels and nurse practitioners, certified nurse midwives, and you know, I admire a lot of the work that they do. I myself have just taken care of so many high-risk patients even before I became an MFM. So that's always been an issue that I struggle with, especially with home births. While that's a good alternative for some women, you know, I don't know, not many of the women that I serve that would be a good alternative for. So I think we have to be very careful in the selection of people that's doing home births. Again, and I think most midwives do really screen their patients very well and work with obstetricians to make sure that's happening. So, but again, a lot of the people, just the people that I work with certainly aren't, you know, good candidates for that. And that's why I'm in the specialty that I'm in.
I want to add that, as shown, most of the pregnancy-related deaths are preventable, and pregnancy itself should be a wonderful and beautiful event and experience, and it shouldn't be ending in a tragic manner. And most of the time, the hypertensive crises we see are related to extremely elevated stress levels, which could be sort of managed with someone who may not be a clinician, but if helping decrease that stress level is brought up in the hospital setting, in addition to the medication we give, I think that's the key, because standard of care alone will not do it. We know that clinicians do deviate from standard of care, and sometimes that is what leads to tragic events. That is what leads to all the complications we see. Women should be treated based on their needs, not just with standard of care. It is in addition to standard of care. And what we've learned that is doulas and nurse midwives tend to give the patient more attention than they would ever get in a hospital setting. That alone can completely drop your blood pressure, put you in a comfortable mindset that could improve your outcome. And I think it should be a combination of the two. So we should really sort of bring that relationship. In most countries, deliveries are done by midwives, not obstetricians. This is the only country where the majority is done by the obstetricians. And we do see that, you know, in other countries, they do tend to have better outcomes based on, again, really the care you provide, that compassion, how the woman is, you know, viewed as important and listened to. Like Ginger Clark said, we really don't do a good job at listening to our patients. A lot of women who died, it was not because the care wasn't there, it was there, but they're just not being listened to.
And that's what I loved about the centering model. I love about the centering model. I was in public health for 10 years prior to going back and doing a fellowship, and we actually administered in my health district the first public health administered centering program in the state of Georgia. And I wish that even for providers that didn't have centering care, the one thing that I loved about it was that you spend more time with patients. You got to know them more. You really knew them personally after doing 2-hour sessions for each visit. But part of the experience that we had in public health with our centering program was we had a multi-specialty team of facilitators. We had a social worker in there during our sessions. We had nurse practitioners, and we didn't have midwives, but we had nurse practitioners that provided most of the care, and sometimes I was in the sessions too. And then we had other providers that came at different times into the sessions. I believe that a lot of the care in this country, prenatal care and care beyond the prenatal care and even postpartum extension would be so much better if our patients were, if that care was delivered by multi-specialty teams. Because different people are going to see different things and address different needs that a provider, a busy provider, will not address. And so I mentioned about the maternal deaths that we had just in the last 2 weeks. Well, one of those deaths was in a patient that I consulted on the hospital, and I think she had no prenatal care, came in with premature rupture membranes, delivered. She was homeless, but while she was homeless, she was under an alias because of some domestic violence issues. She had a C-section, was discharged, and within 2 to 3 weeks of her discharge, she was murdered in a park. Now that was a system that we provided excellent medical care, but that was a systems issue that was not addressed prior to her delivery and going back out there in a situation she came from and was actually, we were protecting her from in the hospital. So again, I think it's crucial, and I think that not only doctors, but all levels of providers, social workers, you know, if we could provide that kind of care, then we would have much better perinatal outcomes here in the United States.
Thank you for that. I agree with that. Do we have time for additional question? We have one standing and one live chat question. So we'll keep our responses brief to this. The question reads, so much of what is prioritized in Massachusetts healthcare policy is focused on value-based care, return on investment, and demonstration of cost containment. How can providers lead the culture shift in systemic values? Admittedly, that's a tough question. It is, from the state perspective, Fifi, I don't know if you'd have comments.
I can speak from a local, back in my public health issue. I mean, we identified the need in South Georgia where we had contiguous counties with no prenatal providers. We didn't have prenatal providers in public health, but I trained actually 2 nurse practitioners on how to do prenatal care. We started our centering program, and we were able to get grant dollars. There was no money from the state, and we actually went to different funders and went to community obstetricians because we don't do deliveries. We had to have their partnership. And so we've got to, I don't know if this is answering that question, but I think it is that we've got to show people what the stakes, where the stakes are, and how that everybody can be a part of the solution. And we partner with a lot of non-traditional providers to bring centering pregnancy to South Georgia.
Thank you.
Yes, hello. Thank you for a great panel. I'm Dr. Maureen Paul. I'm the Director of Family Planning at Beth Israel Deaconess Medical Center. And in the interest of talking about interdisciplinary teams, I just wanted to urge us to include family planning as part of our teams. I recently attended a conference in Las Vegas that was sponsored by the new president of the Society of Maternal Fetal Medicine along with ACOG, and for the first time the Society of Family Planning was part of that, and it had to do with reducing morbidity and mortality, just in women with high-risk medical conditions. And we know that pregnancy intention as well as interpregnancy intervals, affect birth outcomes as well as infant outcomes, and that it's important to think in the preconception period, and have pregnancy planning as well as at the time of discharge, right? Have pregnancy for the next pregnancy, have pregnancy planning be an important element, as well as pregnancy termination being an option for women with high-risk medical conditions, which often is not offered, or the method of choice may not be offered because family planning people are not included in the conversation. So I just wanted to bring that into our conversation, and the question is, how much is kind of this preconception and kind of planning perspective being talked about in the conversation that's happening across the state around maternal reducing maternal mortality?
Not enough.
Not enough. Thank you.
I would say there's been a renewed interest in it, particularly from ACOG around postpartum care and optimizing postpartum care and thinking about it as a continuum and not just a single visit at 6 weeks. And certainly, like, comprehensive family planning, counseling actually belongs in prenatal care to optimize the choices for postpartum, and then to, as you just mentioned, get to an ideal birth spacing sort of plan for all of the positive impacts of that. I think that there is also, interestingly, I think it is at APHA, the sections around maternal health and then sexual and reproductive health were separate. But from what I understand, the president-elect, who I believe is Monica McLemore from UCSF, is deliberately and intentionally integrating those two, because it's kind of a false dichotomy that they shouldn't be in separate camps, that they really need to be considered holistically and sort of on a continuum, given that there's preconception, there's interconception, as many people in this country have more than one pregnancy. And so I think there is a growing interest in melding or bringing those two fields together.
Something I'd also like to add for our state, for Massachusetts, is our state perinatal quality collaborative. As we're doing work implementing these safety bumps for AIM, we're starting with opioid and looking at this maternal mortality issue and the rates there. We are also actively engaged in the state of Massachusetts PIC program, which is the Partners in Contraceptive Choice and Knowledge. That's being led by Kate White through BMC, and through that program that's state funded, the focus is not just simply about contraceptive or the contraceptive methods and training physicians on how, or the providers on how to place, long-acting reversal contraceptives immediately after delivery and those kinds of issues. It's really more about how do we engage in communities and populations of women so that they understand what their contraceptive choices are and raise the knowledge in a way that is culturally humble as we have those conversations. This is something that we are thinking about on the state level and actively engaged in as well. With that said, I think I'm going to start getting an eyebrow raise from Dr. Kaplan if I don't wrap our session up, so she comes to moderate her next group. I want to offer a profuse thank you to the panel that's here. Again, a collection of people who are not only experts in their areas and leading the charge, but also dear colleagues and friends, and so thank you again. I'm David Foster.
I also want to say thank you to our panel, and also thank you to you, Dr. Meadows, for moderating this session. We have a short break, and then we're going to jump right back into our second panel. We have about 10 minutes for the break. There's coffee in the back, and I know there's a lot of people in the room who you want to say hi to, and our panelists will stick around. So we have about time for a 10-minute break. Thank you.
Oh, really? Yeah. I love him. Scott, what's his name? Scott? No, this is another person. Just came in as special. I like that.
Wonderful job, everybody, of meeting that 30-second mark. We're going to continue on with this discussion, and I want to bring up our next moderator for our following panel. It is Dr. Samantha Kaplan. She's an assistant professor at the Department of OBGYN and Assistant Dean for Diversity and Multicultural Affairs at Boston University School of Medicine. She is a good friend, and she is also a past Commonwealth Fund Fellow, also graduating in 2008? 9, that's right, because you interviewed me. That's right, and received her MPH from Harvard School of Public Health as well. With that, Dr. Kaplan.
I'm going to stand to the side just a little bit because I'm so short. So we have heard about systems-based interventions that can impact specifically maternal mortality and morbidity in the perinatal period, layered on top of a conversation about statistics and data gathering. And I think one of the things that really stood out for me in Dr. DeClerc's comments in looking at some of the causative agents was that big area that was attributed to community. And so what we're going to talk about on this panel is the community-based interventions that can be made and ideas, opportunities that exist for us to begin to mitigate some of those disparities beyond the walls that we can control or that we think we can control, we try to control as clinicians or I would say administrators. And I think a lot of what we're talking about in the community falls under that umbrella of what can be done in public health. Some of public health is programming, some is policy, but some of it is actually directly interacting with the public around health. And so that's what we're going to hear about from this panel of experts. I am going to let you know we will have time for questions, and at the end we will have commentary on both panels. So I will try and keep my thoughts limited, although I have one reflection after listening to the first panel and this panel, which I will share at the end, if it doesn't come up. I also am not nearly as social being as Audra, so I have very little personal information to share, but I think we have fantastic panelists from the brief interactions I've had with them, and I'm going to tell you a little bit about them. I think the order that our panelists are going to present is also important because it's really going to bring you into a greater understanding of how important the community and working with community is. So we're going to start out by hearing from Nneka Hall. Nneka is a full-spectrum doula. She is the mother of 4. She has an 18-year-old, a 13-year-old, a child who would be 8, and a 4-year-old. She is a Holman advocate who works with women across a full spectrum of their life, and their life phases, specifically looking at pregnancy and infant loss and maternal mortality within the African-American community. As a full-spectrum doula, she is an international bereavement specialist and a community-centered herbalist and a womb health advocate. She is also part of a number of very important community organizations. She's a member of Vital Village, Boston Community Action Network, Boston's Breastfeeding Coalition, and This Is My Brave, and she was featured on This Is My Brave in January of 2019 within the documentary. She's going to talk to us today from both a personal and professional perspective on the importance of support of women to impact perinatal mortality, and not just specifically when we tend to think about it within the period of birth, but in a much broader view in the antenatal and postpartum period and how that can impact mortality for women.
One second, it's technical. I normally don't like working with these things because I'm not a very tech-savvy person, so bear with me, and we'll get through this. First, paying homage to my ancestors who have somehow managed to fill the entire month of May with speaking engagements. However, when I received the email from Ian inviting me to speak here, I thought it was a prank for one of my older children or a dear friend, and I'm so happy I didn't press send on the initial response I had written. But more seriously, as a young girl, one of the first words I learned was statistic. I somehow became fixated on it and prayed that I would not grow up to be one. I honestly wished someone would have informed me that because of my color, the color of my skin, or my ethnicity, it was my birthright. On August 26, 2010, I was blindsided by a statistic that I should have known about. At 39 weeks gestational age, my daughter died, and my OB comforted me with 3 words: these things happen. August 27, 2010 was the day my daughter arrived earthside. It was also my 37th birthday. My year of fog began. August 27, 2011, I looked at my children, who were then 11 and 6, looked at their faces as they screamed, sang happy birthday to me and their sister, who should have been there to celebrate with us. They were pleased and I wasn't. I faked a smile and was able to contain the tears until I ran out of the room. But tears are cleansing, and for the first time in a year, I was able to see a little bit through that fog. I needed answers, and for the first time, I found the strength to review my medical records. I later found a doctor who was able to decipher the medical jargon, because clearly I had no idea about the chicken scratch or terminology, what have you, and discovered that I should not be here. You're looking at a ghost. I'm a ghost who was reborn on her 37th birthday. I complained about my daughter's actions and my feelings throughout my entire pregnancy. And sadly, because of my history with depression and marital problems, I was sent for a psych consult. Proteinuria was labeled as an unclean catch for an entire trimester. A slightly raised blood pressure was just looked at a normal blood pressure result. And as a result, my daughter passed away. Cause of death, asphyxia. Now I can close this and we'll talk. 2011, I became a doula. I thought that I would be able to work with others and sort of bridge the gap between, between lay people such as me and moms who look like me. I could tell them things, learn the terminology that I could not understand at the time. And mind you, at the time of my loss, I was the mom of 2 already. So I'd already experienced the pleasures, the joys related with having live births. And now I can look back at the birth of and this is my rainbow baby, my 4-year-old. I can look at the death of my daughter as being my rebirth, because now I'm able to focus on helping others and make sure that they know a little bit more and they're able to use their voices and to be heard so that they can be heard. I realize as a doula, I'm not allowed to speak for them, but they are allowed to speak for themselves. And I just have to credit the slides that I'm using came from one of my sister doulas in Connecticut, who said, oh, go ahead and take that information. It was just easier to use their jargon that they're using for this doula bill than to recreate my own. So you can see here, what is a doula? Everyone here who has given birth, have you had a doula? Does anyone, before this definition, did anyone in here not know what a doula was? Yes, no, no, no. Oh, great. This is the first room I've ever been in where everyone knows what a doula is. So, doula care increases the likelihood of a shorter labor, a spontaneous vaginal delivery, higher APGAR scores, and a positive childbirth experience. Now, I had never heard of a doula before 2011, and I happened to stumble on the term and had to know more. See, that's my problem. I have to know too much. There are times when my children say to me, come on, Mom, just accept it for what it is. And I'm not that type of person.
reduces the likelihood of costly interventions, reduces spending on non-beneficial medical procedures, avoidable complications, and preventable chronic conditions, improves health outcomes for both mothers and babies. We also bridge the gap between community services, so we can go into the community, we partner with community organizations such as Boston's Community Action Network. Anna and Demisha are here to support from the Community Action Network. I'm proud to say that in our most recent All Can meeting, we found out that because of our work since 2011, the infant mortality rate has dropped by 37%. And currently, the CAN is working on a FEMA bill as well as preconception health, a variety of preconception health things. Most recently, we're working on interviewing African American and women who identify as Black to see how the community relates to them, if they feel like they're being judged, if they're being spoken against, or what have you. I'm sorry, I gotta get through these slides. Patients who have hired a doula reported feeling valued, having had a voice in consequential childbirth decisions. We slow things down. We translate. We're there for them before they get pregnant, during the pregnancies, as well as that first 40 days postpartum. Now, at least I am. I had the opportunity to travel to New Mexico in December and take the best training in the world. NA Traditions postpartum care training. If any of you have the opportunity to take that training, it is also an online training. I know most of you have spent your lives and most of your money becoming doctors. However, this will put things into a different frame for you as birth and postpartum providers. It was a life-changing experience for me. I hadn't seen the postpartum phase so eloquently supported, and it taught people from different socioeconomic statuses how to provide support in their communities. One thing that I would like to say in closing, and I'm sorry, there are several organizations that you guys should become familiar with. Even within the hospitals that you service, there are doula programs, volunteer doula programs, that your clients, if they don't have the support, should be referred to. I've had clients who could not afford my fees, and I said, well, why are you trying to pay me when there's a volunteer program? Well, what happens is, if you're not coming in on Medicare, they don't refer. They assume you have the money to pay the $1,500, $2,000, $2,500 fee of the, for the doula, when that's not always the case. So look into your systems to see how we are there and who we are. Oh, I have 2 minutes? Okay. How we are there to support you. Also there, we have the Birthing Project USA, which sets up systems of community kitchen talks in churches and community centers that can be formed just by talking to grandmas. They come in and they provide support from conception through the first year of life, and they come in and they support the families as doulas if they cannot afford a doula. We also have Bridging the Chasm, which is a new program that should definitely be looked into. There are several different work groups going on now, and these are people who are from all over the United States who are coming together to figure out why this is happening, why mothers and babies are dying. In the Boston area, I love the Smart from the Start program. If I have a family who definitely needs the community help, I refer them to Smart from the Start, which has several different locations, and they provide support from conception through age 1 and also beyond. What they do is they pair them up with someone in their program, and they walk them through their pregnancies. They make sure they make their doctor's appointments, they make sure things are understood in lay language, and this is crucial, especially for people, and this is a program for low-income families. I'm saying the entire family unit, not just mom, because we focus on mom during pregnancies, when it should be the entire family unit. And if mom is a single parent, they help to provide that excess support by linking them to other community supports. And this is my angel baby, Anaya Marie, who would be turning 9 in August. This presentation is in memory of all mothers and babies who have died before birth and in the year that has followed. Thank you.
So our next panelist is going to talk a little bit about the community from a different perspective. She's an assistant professor at the American International College at the School of Health Sciences in the Public Health Program at Springfield and an adjunct professor at Holyoke Community College. She is currently president of the board of directors and the executive director of Mother Woman. This is Dana Campbell, who also is in the process of pursuing her PhD in health services policy and management at the University of South Carolina. So very busy, and is going to talk to us today about community-based participatory programming. So this is what we all learned when we were getting our MPHs, is a critical way to make sure that what you're doing is not to the community or for the community, but with the community. And perhaps you even invite the community to be involved in the programming themselves.
What wasn't mentioned, in my spare time, I'm raising a 6-year-old daughter. So, my name is Dana Campbell, and so I want to tell you a little bit about Mother Woman and the programming that Mother Woman has been doing to include community and identifying the concerns of community and involving community and actually coming up with solutions or addressing those kinds of concerns. Just a little bit about Mother Woman. It started in 1999 by a few women in the Hampshire County area of the state. Some of you might know that. It's like Hadley area, Amherst, Northampton. And it was to address the lack of resources for postpartum moms, particularly as it relates to mental health issues. Both could be PPD, anxiety, could be just baby blues, or even just social isolation. And they came up with a model for creating a peer support group and trained lots of people on this method. And so then in 2004 it became a 501c3. And then, it's just much like any nonprofit, they had their ups and downs. And in 2016, there were some major changes to the organization. I was asked to come on to the board in December of 2016. And then the organization moved from Hadley, Massachusetts to Holyoke, which is somewhere in between the urban-ness of Springfield and sort of the ruralness of Hampshire County. And then in the midst of me starting out as part of the board, I started asking questions. I think the researchness of me came out, and I asked, what is the data? Like, where's the data? What research have you done? How is this getting to vulnerable populations? Who are you training? Is this accessible? Who's sitting on the board? Who, and then next thing I know, I blinked and I became the president. They voted me president. And like I had time to do this. But anyway, that's what essentially happened. And so I asked a few of the people that remained on the board to come along with me on a journey to sort of rethink how we are approaching the services that we are providing to moms or potential moms. And so what I'm going to present to you is sort of a combination of using what was already there and then where we're hoping to take the organization. So these are sort of the 3 tiers of things that we sort of visualize. Oh, I forgot to tell you, let me tell you the mission. The mission, it's still a work in progress. We have changed the mission and probably will change it again. But right now it is to promote the resilience and empowerment of mothers and their communities by building community capacity and advocating for just policies through evidence-based research and grassroots organizing. And so this slide shows you the 3 tiers of what we are attempting to do. The first being community capacity, building the capacity to actually address the needs of moms. And doing some research, which I will explain a little bit about our project called Mama's Voice. And then Mother Woman has historically been involved in some advocacy projects, including the very last one, the Pregnant Workers Fairness Act, which actually was started through conversations from Mother Woman by a woman named Laura Sylvester. And we successfully got this passed. I hope you all have heard about it. Your employer should have told you. So starting at the bottom in the community capacity is the facilitator training, which is what I had mentioned before, and this is training anyone who is interested in running a support group, and we have a model for that. And it can be for, it was started primarily for PPD, but has been expanded to a wide variety of areas: teen moms, women in recovery, women in prison, I mean, just, whatever the needs, bereavement, special needs, those kind of things. And then if you move up, one of the things that we noticed in doing some of our work was that many of the providers that are, there's not a lot of providers who are doing evidence-based therapy to address PPD or postpartum mood disorders. And so cognitive behavior therapy is one of them, so we started offering that training. And then we also recognized that, at least in the western part of the state, that a lot of the providers did not look like the people who needed the assistance. So we started to really think about ways in which we can recruit providers of color, LGBTQ, et cetera, to provide services. And then I wasn't going to talk about this before, but based on some of the conversations earlier, I thought including a rich conversation about cultural humility. Some of you may or may not have heard about cultural humility. It is a philosophy in which, or a philosophy or slash a tool to look at the relationships and their interactions between providers or service organizations and patients and their clients. And it comes out of work out of Children's Hospital of Oakland, two pediatricians out of there, Dr. Melanie Turbalon and Jan Marie Garcia. So if anybody's interested, I can give you a little bit more information about that. But one of the things that we had decided is that we were going to focus on vulnerable populations and disenfranchised populations, and so cultural humility has really taken on a huge role in our work, and we are committed to being a culturally humble organization, or at least be on that journey. So we also provide trainings in that. And then the CPPSM is the model that we're using to bring together groups of people to work on perinatal issues and support. So I'll talk about that. And then our evidence-based project is Mama's Voice. So this is the original CPSM, and there's 12 coalitions across the state. Some are operating really well. Franklin County has a very successful coalition. They have actually leveraged their position to receive a $1 million grant to do some work in the prisons. And then there are some coalitions that are not doing quite as well, but we're hoping to receive some funds to help those coalitions. But this was the idea, that's the model, and it's sort of circular, so that You bring leaders together, you do some training, you provide technical support, but the whole idea is to get moms screened for PPD and then into treatment. And we had decided to change the model a little bit and add a couple of components, and so these are the three. The first one is making it more community-based, and so when I came on and I started looking at the coalitions, I recognized that it was provider-heavy. So whether it was OBs, whether it was midwives, doulas, service providers, and less people who had a different kind of vested interest in that, in the issue. And so we are reaching out to the coalitions to say, hey, you need to really think about how you can bring moms onto your coalition so that you can stop providing solutions too, and asking people what they actually need and to provide, coming up with solutions with. And then I mentioned the cultural humility. Again, we are providing training so that anybody who's sitting on these coalitions actually know how to interact or use this as a tool to interact with the people that they're providing services to. And then the last one I'd already mentioned is that we have noticed that we lack the professionals to address the issues. Okay. And then the last thing I wanted to talk quickly about is the research project that we're working on called Mama's Voice. And voice is voicing our individual cultural experiences. And this is actually a photo voice project. I heard Dr. Clark make the comment about not using qualitative, which I thought was kind of funny because this is a qualitative. But it is a photo voice project that we have been, this is about 1.5 years that we have been working on, where we're asking moms in the Holyoke area and the Springfield area to provide photos of what it means to be a mom of color in those spaces. And I presented at APHA the results of our second round last November. And so if anybody wants to hear any more about that, I'd love to talk to you about it. But it is very interesting to see the ways in which people experience the regular stressors, but then there are some that are very culturally based that are often not addressed. And I think this is one way to sort of identify that. The other thing is we thought about looking at how can we redefine what it means to have mental health issues as a mom of color. Maybe it's not PPD or anxiety, but maybe it's high levels of stress that, and I think you all know this, but that affect not just our mental health, but our physical health as well. But how is that captured on a screening tool that's only looking for depression or anxiety or OCD? And so this tool, this process, we're hoping to be able to redefine what it means to have some issues that need to be addressed. And that's it. Thank you.
Sort of circling back to one of our organizations here in Massachusetts. We're going to be hearing from Karen Dowd, who is the Maternal and Child Health Director for the Title V programs in Massachusetts and the Director of Pregnancy, Infancy, and Early Childhood within the Massachusetts Department of Public Health. Including and outside of that spectrum, she's been doing work here and internationally for over 40 years, focusing on providing support to women and their families to ensure optimal health and economic outcomes, and attempting to address the social factors that contribute to maternal mortality and morbidity, and the inequity. She's very interested in strengthening a system of care that addresses the social and racial justice that that dismantles the structural systems that have led to our current situation, and trying to ensure that women and their families, again, families are very important, receive all the support that they need, antepartum, peripartum, and postpartum.
So, good afternoon. I'm in a great position of following on a lot of people who have really laid the groundwork for some of the things that I'm going to say. I wanted to say that although I work at the state level, what I really feel that I'm doing is trying to bridge the community, the chasm between the community voice and policy and the state level. So although we work at the state level, much of what we do really has to be and must be grounded in the voices of the community, and I think we've heard of that from many people, starting with Gene DeClercq and his Listen to Women, which was number 3 of his, and also Dr. Molina really spoke to the need in a clinical practice to be very mindful of how we speak with people. And looking at implicit bias, I want to add to that implicit bias piece, really understanding power dynamics within a room. That is critically important, and I'll talk to that a bit more later. And with that, I'm going to figure out how to press forward. Enter. There we go. Got it. So I'm going to talk about 3 community strategies that we use at the Department of Public Health to really listen to community voices. The first is we have some federal funding and a little bit of state funding to provide home visiting services to pregnant and parenting families. The first is funded through the federal MCV, which is Maternal Infant Early Childhood Home Visiting Program. And we've used some funding from MCV to also implement a program called Welcome Family, which is a one-time postpartum universally offered home visit in certain communities. And the third one is a state, what we call, the feds have this, the federal government has this, they have evidence-based, and then they have this affectionate term, a homegrown program. So the EIPP is our homegrown Massachusetts version. The other piece I want to talk to a little bit more is community network mapping. I mean, how do we look at the system of care from the community level? And we have a very structured approach that we're hoping to use across multiple programs. And then the Title V needs assessment, that is, and I'll get a little bit more into that later, but Title V is Title V of the Social Security Act that provides funding to all states to support families and children, including those with special health needs. So, home visiting. I think the goal for home visiting is really to be that link, that liaison between the medical system or the system of services and with families. Home visitors in most programs they're either community health workers, one of the models EIPP, which I had mentioned. There's a nurse and there's a social worker or a clinical specialist that may be a mental health specialist. And then in some, they're peer moms in recovery, for example, in some of the home visiting programs that are more specific to families affected by substance use. So what happens in the home visiting, I think the point is to really meet families where they are, to really hear and understand what their challenges and issues are, and to really promote a different paradigm, rather than them being those people or low income or people who need help, really support them, starting from where they are, listening to their stories, and really looking at reframing and taking more of a strength-based approach. What have they done well in the past? How can they be positive parents? What do they need? What is their understanding of how the system has treated them? And how can they really sort of walk along the sides, similar to what NECA was talking about in terms of a doula. That is the role that a lot of the home visitors play. And when we were thinking of the home visiting, and I also wanted to circle back to one of the questions, a huge part of the home visiting program is really speaking with families after they've delivered about their intentions for having another child or not. And even 2 or 3 years out, the question is always, do you have the intention of being pregnant, and then support them in whatever their decision is. And that is one thing that's a critical part of our home visiting program. So, but this is not usually where we talk about, this is the immediate postpartum. These visits take place between 4 and 8 weeks postpartum. And we only have enough money at this point to universally offer this in 5 communities. We're hoping to figure out a mechanism to sustain this because we've had a lot of really positive feedback. So what people have felt is that this is a point of intersection between giving birth and the rest of their lives. And you know, when they're pregnant, a lot of focus is on the pregnancy, and then the baby, and then the baby's born, and then suddenly the woman sort of drops out of view. So we really wanted a program that focused and supported the woman and tried to figure out what she wanted and how to support her in parenting. So you can go look at some of the research, and we were identified as a promising approach, and we have written a couple of articles. And at this point, I really think there's a lot of value in thinking about this as a potential policy initiative across the state. Oregon has just passed legislation that provides a universally offered 1 to 3 visits postpartum, and that's part of their early childhood bundle, if you will, in Oregon. So we're hoping to learn from them. As I said, I can't start in the community without thinking systems-wide as well. So, what do we do at the community level more specifically? One thing we realized when we often went out to the communities and talked to them was that we were encouraging families to participate on community coalitions or to join advisory groups. But what that didn't recognize, I want to circle back to the idea of the power dynamic. What we found often was that we had tokenism on these advisory committees and on these coalitions, and we really wanted to be a little more strategic about how we formed a coalition. And so what we're doing in one community and hoping to replicate it in other communities is that we really start first with families with lived experience in a network mapping exercise that, from their perspective, asks them what about their journey through the system of the healthcare system? What worked? What didn't work? What was helpful? What wasn't helpful? This particular network mapping we're doing with families in recovery or with substance use disorders, specifically opioid use disorders, but it could be applied for any experience. And once they have done their network mapping and we have looked at what are the challenges, then we sort of encapsulate all of that and ask which of them would like to be community leaders and speaking out on what their experience was. And soon after that, we do a provider and community leader network mapping, which is interesting because usually that looks totally different from the family network mapping. And so the families will have their perception of the systems. Then we'll get the providers, and the more diverse the providers and the community leaders, the more rich the network mapping is. And then they will come up with their solutions or their ideas or their trigger points, things that aren't working. Then we bring everyone together, and that's the point at which the real dialogue and coalition building happens. At that point, we ask people to talk about shared vision, who's going to be the backbone organizations from both perspectives. What would be the indicators of success and how can they align their activities? And one of the most critical pieces is having a communication structure. And then after that has coalesced and there's a coalition that has come up with a strategic plan, then we have learning collaboratives across the state so communities can really learn from each other. And I thought I'd have all the time in the world, and now I'm really having to go quickly. The Title V needs assessment, I'm not going to go too much into discussion about what Title V is. Just to say that there is a very strong quantitative part, which Fifi, my colleague, leads, and then there's a strong qualitative part. Before I was in public health, and before I was a nurse, I actually was an anthropologist. So this is back to my roots. And what we do in our needs assessment, every 5 years we're required as a part of the funding to conduct a comprehensive state needs assessment that then dictates what our state priorities are for the next 5 years. So that's a huge task, and we want to get it right. And we want to look at the data and look at trends, and we interpret what might be happening, but what we really want is the voice of communities. And so we have a whole series of focus groups. Some of the ones that we had the last time around, we're just gearing up for our 2020 needs assessment now, but in 2015, we spoke with moms who had given birth, moms of color, Hispanic groups. We had a great LGBTQ group, and in these groups it's really fun. Nobody has to use their real name, and everything is de-identified. So the LGBTQ came up with the great, we had Mickey Mouse, and we had all kinds of people on that team. Incarcerated parents, their perspective is invaluable. If you talk about people who are most oppressed and most disenfranchised and most disconnected from their families, I would say it's the incarcerated parents. And teen parents. So in addition to focus groups, we do surveys, and we use all of this information, we collate it to determine our state priorities. And the one thing I want to say that happened, I'm not going to go into what our state priorities are, and you can look them up. Title V information system, look up Massachusetts and you'll see all our priorities. But one thing that really came out strong and clear from the series of focus groups, from every single focus group, was the need to address racism. And I had teenagers stand up and to say in focus groups, I am not standing for the Pledge of Allegiance until there's liberty and justice for all, and I'm not seeing that. And it just gave me chills just to hear how this was a consistent theme. And because of that, one of the priorities that we set in our state was to really address health inequities by addressing social justice, racial justice specifically, and leading with race in everything that we do, in terms of even looking at the data, looking at what our policies are internally, and looking at how we can really frame the principles for the contracted vendors in our states. Okay, this is one of the groups. This is an actual real picture. And that's how you can get in touch with me.
Okay. So we are going to have about 25 minutes maybe of questions, right? And then we're going to have some commentating. Is that right? Time? Okay, good. I wanted to just say a couple things. So, so I was thinking when I had the opportunity to moderate this panel, yes, I'm an OBGYN, and yes, I do this every day, and yes, I work at Boston Medical Center, but what are my own individual thoughts about this, and why would this make sense, particularly this community element? And I think, there are a couple things that I want to mention very quickly that I think were touched upon that I want to highlight so that they are addressing questions and perhaps in commentary by Dr. Bryant when she comes to speak. I think centering, although I did hear from Karen, I actually was at a talk that she and Fifi were on Monday night last week, I think. Centering has not been shown to be as effective as we would like to think that it would be in affecting outcomes. However, as someone who's done centering in pregnancy for the last 7 or 8 years, I would say I think that in addition to learning your patients well as providers, there is a middle tier of community that is created amongst those women that can oftentimes help to supplement whatever the community is and serve almost as a group doula-like experience for some of those women, because there is support that we see before delivery and even extending beyond delivery within that community. And I've had centering groups where people come back, 2 women to the same group several years later who stayed in touch ever since their, between their pregnancies, which I think is extraordinary. The second thing is I wanted to just mention this whole idea of interdisciplinary approaches. So we, yes, should include family planning, and in fact, one of the fellows at Boston Medical Center, the Family Planning Fellows, is looking at the impact of racism on women around reproductive choices beyond pregnancy, such as contraception, and abortion, and spacing. And does racism disempower women, and what are the stressors and the expectations within society related to race for women as they make these choices? But don't forget, as OBGYNs, we lose women. They leave us and they go see primary care doctors, or they go see they see their family medicine doctor, or they don't see anybody until they come back and they're pregnant again. And we have not yet figured out how to include that discipline, whoever that is, and that is many people. That is some emergency medicine doctors, it's some internists. Sometimes it's the pediatricians who are talking to the mothers when they're seeing the children, and we have yet to even begin to explore that, and I think that's another dimension. Questions for our panel? I have a question, and then it looks like you have a question too. But so this is in keeping with what Dr. Molina was talking about in terms of concordance. So this is specifically for you, Nneka, in terms of, do you think it matters that there be racial, cultural, ethnic, experiential concordance between doulas and patients, and how does that impact the discordance that we see given our health provider workforce? And I'm going to include midwives in that because there are not a lot of midwives of color either, actually, and our patients that we are currently discussing here, our patients of color.
Well, I think the second part of that question can be answered by looking at who is actually in the room today. Look around. First portion, I think walking into a space and seeing a doctor that looks like me, or a midwife that looks like me, or a nurse that looks like me, I'm more open to tell them the truth about what's going on with me, regardless of whether I'm going to see an OB. Case in point, my fourth pregnancy, my rainbow pregnancy, I had the pleasure of having Dr. Laura Riley, and I thank God I was 41, because I probably would have gone back to her a few times before she switched I would have just gotten pregnant for that experience. Seriously, I mean, it was the best experience ever to be cared for my birth plan to be taken as Bible, to negotiate my 37-week induction. I went to her knowing more than I'd ever known before, because with the first 3 pregnancies, I didn't even know what a doula was. That was the only pregnancy that I was aware of how my body worked. And I think that's another key, teaching our women before they get pregnant how their body works, going into our communities saying this is what a doula does, this is how she can, or he can provide support to you throughout your pregnancy, and so on and so forth. As a person of color talking to another person of color, this is why I became involved with the Community Action Network. I've been involved with them from day one, pretty much, from the first year of inception, and I plan to be with them until they're no longer there. Because I look around and I see a beautiful rainbow. No one is belittled. Everyone understands, and if they don't understand, there's someone there who can explain it to the fullest. We have all come together, even with planning the mission, planning whatever. There's no one person making that decision for us. It's a true community, and what a community should look like and be modeled after. Did I answer?
I think so.
Okay.
Can I also say something?
Absolutely.
One thing I had meant to mention was, even in research or doing focus groups or the needs assessment, it's critically important to have people who are running the groups mirror the communities or be part of the communities. And so one thing we're doing this time that we're doing the needs assessment is really training community facilitators in running the groups. I mean, last time, I love being in those focus groups, but I'm white, I'm old, it's like, I think that I'm not that old, but But I really believe that having this concept of participatory research, as well as, similar to what Dana was saying about participatory program development, is critical. Because we're not going to really know what, people may not speak with such authenticity and may not feel that they can speak, truth to power, when power is sitting right in front of them, so much as they can really talk about their experience with people who they feel that commonality with. So that is something we're really excited about doing this time, is really training the community researchers.
Do you want to come? Yeah. I want to comment.
For recording purposes.
I think I'm still concerned that we have to choose where we go for care, try to find the people who look like us. In terms of the population in the United States, we have 80% or more white and less of the other groups. So the workforce itself will never mirror the population to the extent we want. When you walk, I was giving a talk at the UMass Medical School. I was shocked that there were only like 2 African American students in the classroom. There were like over 200 people. So we are not allowing enough of the African American people or other people of color to be in the schools to begin with, to be in the professions. So the expectation that we would see them is kind of making the choices difficult for us. It would require that you travel from your town to the town where you can find a nice Dr. Meadows to give you a hug when you're walking around us, or not to go at all. We do see people who decide not to go at all, right? I think we need to be in a place where we can freely walk in any hospital or community health center, knowing that we would be cared for like a human being. Physicians, we swear, when we finish our medical degree, we've completely forgotten what it is to not cause harm, which is what we swore. All of us have. So I think the conversation should go back to how do we create a space in our services, hospitals, community health centers, everywhere, where people can come and feel safe. Because at least as far as I'm concerned, you call the hospital a place where you go to feel well. It's a place where you get well, we get well. How can we not provide that? I think it's pretty simple. We've forgotten the basic human right and why we're physicians. It's either you like the profession, you do your job, or you don't. So we need to restate the conversation. And the other comment is related to the one key question, which has become pretty popular. In some communities, reproductive health is a private matter. When I have sex and when I get pregnant, that's my business. It's none of your business. So not everybody is open to having those conversations. From a religious perspective, in some religions, like Muslims, they're required to do whatever, to be a good wife. So having the conversation in a different way might help address the problem. You can't just tell them, when are you planning on being pregnant? When are you going to have sex? No, hell, nobody knows that. So I think we need to think about how we do that conversation. I know it's awkward coming from an obstetrician, talking about family planning, but it's a reality. It's something I learned from the patients. So I just wanted to put that out there too.
Can I respond to that? I often say to my daughter, I'm not that kind of doctor, so I'm not going to speak for a physician because I'm not a provider. But one of the things that I've learned in cultural humility, particularly coming from providers, is finding some kind of tool or philosophy in this case that you practice and how you interact with your patients. And so if you are interested in it, I would tell you to. Does anybody, y'all have heard of cultural humility? Some people. Okay. So Dr. Tourbillon is very, and I think she's coming to Boston in October, by the way, to do a training. So if I don't know who's sponsoring it out, if you want to find that out. But I think having those conversations and learning how to address the power imbalances. I watch my grandparents, for example, go in and not ask a question at all because there's this sense that the physician knows all, and who am I to question, even if it's me, even if it's my body. And I think a lot of people have that. And what ends up happening is if we're the authority, we take that power on. And we need to learn to mitigate that power. And some people do it better than others. And I think that also is with service providers, right? I think it's not just in provider-patient relationships. So that's one of the reasons, I really like cultural humility, because I think it's a really good tool to really step back and think about, who you are and what do you bring to the table, and then how do you address other people, even if you are in a power position. Because you're right, every place that we go is not, the person's not gonna look like us. And so I have to know, as an African-American woman, that the person on the other side is going to follow some kind of strategy that's going to make me feel comfortable or as safe as I possibly can feel. But I don't know that. I have no reason to think that even.
Thank you. This was an enlightening panel. I have to say, Karen, you enlightened me on something that I really didn't think about. I like to say often that our state PQC is the formal bridge between the clinical care system and community, and not community, public health activity. And the way you brought it up around home visiting, it seems like that's a natural one. Now, two questions, one for you and one for you, Nika, on this issue. And that would be, in the structuring of home visiting, has it ever been discussed to have home visitors interface with women during their prenatal care so that they're more likely to accept home visiting, since the rates were only 50%? And then I'll just quickly ask the next question and then let you both speak. And then Nika, specifically to doula care, I was at a delivery last week with a woman who had a baby by herself, and I was blown away. I had to leave the delivery despite the fact the anesthesiologist is going to lose her mind because this woman had HELLP syndrome, and I'm trying to find somebody who can come in here to the hospital and be with her for this delivery. And I found out afterwards that the Brigham does have a doula center, a service for women, but it wasn't advertised, and so I didn't know how to, even if I would have known beforehand, I wouldn't have known how to use it in that way. And so as I put in a plug for part of the conversation we're going to have tomorrow, my question to you is, the Reed Scholars tomorrow are going to be talking a little about digital health, and I haven't heard in any of our conversations where technology plays a role in this, and I'm wondering if there are apps or something related to doula services so that we can have a better conversation of knowing how to help connect women to people who want to be connected and support them. So I'll let you answer, Karen, and then come back to that.
Sure. Some of the home visiting programs are really community health workers, and well, they don't consider themselves community health workers so much as peer support. They're paraprofessionals. They receive extensive training in motivational interviewing and working with families, and yes, they do connect with them in pregnancy, and yes, their role really is to link with the prenatal care provider. One of the home visiting, our homegrown home visiting, there's a nurse, there's a mental health provider or a social worker, and a community health worker, and the nurse does a lot of that linking around with around the issue of pregnancy and who do they want when they're in labor, and connecting them with the doula. And in fact, one of the programs, the EIPP program in Somerville, connects with the Cambridge Health Alliance doula program and really tries to work with the doulas to get them hooked up. So they do. I think it really helps a lot of people to have a nurse on the home visiting team, because sometimes, they want, let's see, how do I phrase this? Sometimes they really want someone who can interpret the medical system in a way that they feel heard, tell me about what hypertension is, tell me about, they threw this word at me and that word, and having a clinical person on the home visiting team really helps with that translation. So, yep, I'd love to have, again, looking to our international partners, I'd love to have universal home visiting for everyone, prenatally up through 5 years of age. But
sort of respond. We are seeking a doula. We currently have a doula bill in the House, and we're tweaking that a little bit to reflect not only birth, but postpartum and bereavement support. So I'll be meeting with someone in a couple of weeks so that we can add in a specific amount of pay, so that not only will parents who are on Medicaid, Medicare, whichever, sorry, thank you, be supported via birth, but also throughout the first 40 days postpartum. In response to the technological support, we do have a Mass Doulas, I don't want to say website, but since you're in the Boston area, we do have sort of a hotline through BASC, and I will make sure that the information is provided. I'll send email the information as soon as I get home. Different information, because it reaches the Mass Doulas email, or we have like this Google group where if someone needs a low-cost or free doula, or if someone can afford to pay, it's posted in this group, tells the person when they're giving birth, where they're giving birth, etc., and we just respond as needed. But for an emergency situation, you should have been able to contact Anastasia at the Brigham and say, we need someone now, and someone should have been there. Ideally, we would follow the Brooklyn, New York Public Health Commission, where they have a doula program that's built into their Public Health Commission, and hopefully we'll get there. I'd love to see a postpartum doula program to support a family not just with 1 to 3 visits, but with the first 40 days postpartum to a year. And with this doula bill, that can happen because insurance will pay and we don't have to find funding to support that. Does that answer your question?
It does, thank you. Other questions? Do you have another one? Is that what you're saying?
No, Thank you very much. Actually, I wanted to follow back I really appreciate the question about do we have to look for providers that will take care of me as a human being? And I think my question it sparked my thinking, and I love the fact of the cultural humility concept of as provider and also as a human being. What is more important? Do I need to seek a racially congruent provider or a culturally congruent provider if we're all human beings? And I just feel that the concept of racial differences, we don't choose that. But cultural differences, we can get trained, we should be able to embrace, and that is the opportunity of change instead of probably reinforcing a little bit more toward racial segregation. So I don't know if I can hear a little bit more about how you think, I really appreciate your knowledge, the doulas and thing, and for example, my patient, I was raised Hispanic, and when the patient come in, they ask for La Chinita. And that feels very, probably for people who feel that she has a name, but having a name does not make you be identified, but being called La Chinita, they have the freedom to call me like that, that is what helped me be identified with them. And I would love to hear from the panel and also from the audience about the cultural congruence of provider with patients. Thanks.
I can say something about cultural congruence really quickly. So there have been some studies that have been done that look at gender, they look at race, they look at socioeconomics, they look at linguistic concordance, and they look at all of these things. And while all of those are very important, and there's a number of studies that will show that there are certainly increased adherence to medications, perhaps some of the ones that have been touted most frequently, this is a lot of Lisa Cooper's work, where they're looking at diastolic and systolic blood pressure numbers with concordance and finger sticks and things like that. But I think that the other piece, the body of literature, speaks to creating these spaces for both cultural humility, cultural appreciation, and flattening of power dynamics. And I think the way that at least the AAMC, the Association of American Medical Colleges, is looking at it right now is around this idea of curricula around racism and advocacy. And in medical school, trying to address how it is that we begin to teach students the history of the impact of racism, discrimination, socioeconomics, politics such as redlining, policy and legislation on health outcomes. And if we are able to begin to educate medical students about that, we would then cultivate a generation of physicians where concordance matters less, significantly less, because they are coming in with a very clear understanding of how what they are bringing to the room and how the patient, what patients bring to the room impacts that interaction in the context of the history of racism, discrimination, socioeconomics, geographics, immigrant status, gender, sexual orientation, and all of the things that we know play a significant role in increasing distrust. And honestly, not only distrust, but misunderstanding between providers and patients. And that you actually probably Dr. Molina has something to say too as well as Dana. Do you want to say something?
Oh, I'm sorry. I was just going to say, like, as a public health professional, I'd say that exact same thing sort of is happening. You know, in the earlier days of my training, we were really nothing about racism and discrimination. And you know, now it's sort of a buzzword, and students are getting it earlier and earlier. And I think it is extremely important because some of the policies, some of the practices have some overtly racist tones to them, and some, you know, underground sort of racial tones to them, racism tones to them as well, and so the distrust between community and provider community and public health professional, whoever is there, and so until we start getting that information, I think, and putting it into training programs, we're going to be in the same situation. And I think race concordance is extremely important, but I don't think, I agree with you that I think if people are beginning to understand that everybody's people aren't coming at it from a racist perspective, then that trust will be there regardless.
Other comments?
There's a program out of the Community Training Institute that teaches, I was recently a part of a cohort there that really delved into racism and how it starts, how it forms, how it keeps going, and then how to break it down. I mean, I've been Black my entire life, and I had never seen anything like that in my life, and I went home and was blown away, and I've been putting things in like little triangles ever since. But that's a good place to start, getting trainings like that into facilities to help people see that even though they're Black, they still have these biases towards other Black people, and so on and so forth. So that's an excellent place to start. And also looking at models around the United States that work, such as Jenny Joseph's model out in Orlando. I'm trying to bring her here for her community health training in October. So be on the lookout for that, because she has recently rolled out a model that helps to put together, it helps us to get a feel for her her centered-based program out of Orlando. And she's sharing that knowledge, and I can't wait until she gets here because it's so very needed here in the Boston community.
So we have 2 minutes. Do you have a very short question with a very short answer, maybe?
I do.
Oh, yeah? Okay, go ahead.
A few people today have brought up the importance of having more reproductive options available to women. And full disclosure, I almost died 2 years ago from side effects from birth control pills. And I know a young lady that died 3 weeks ago, 24-year-old, from pulmonary embolism from birth control pills. And we know that many of the same factors that increase rates for maternal health mortality rates also increase side effects to birth control options. And just in the discussion today, I don't want people to leave thinking that reproduction is the solution, and making sure that we take a holistic approach to this issue.
Okay. So we are going to have some commentary today from somebody I'm so excited to introduce, because I will say that in the 10 years since I finished the fellowship, we have been essentially in the same city and never actually worked together. But we are part of a very rich group of OBGYNs who completed the fellowship, who we would like a picture with actually after this panel. So do not leave, because there's a lot of us. It's very exciting. So Alison Bryant is an associate professor of obstetrics, gynecology, and reproductive sciences at Harvard Medical School. She is entirely educated within that system. Took a short little jaunt to California, where she was at UCSF doing some of the work that she then came back here to do, which is looking at Black infant health and women's health on the San Francisco Department of Health Women's Advisory Board. Here at MGH now, she's a vice chair of quality, equity, and safety in the Department of OBGYN, and this is a role that she designed, because we hear a lot about quality and safety. The equity is the part I imagine she stuck in there, in an effort to try and underscore the role that equity in healthcare plays in terms of creating quality care across how we provide health to our patients within institutions. There's a lot of other stuff on here. Most notably, you see a lot of stuff at ACOG, which is our both legislative and clinically a clinical advising organization. They set our guidelines, and she actually has co-authored the Alliance for Innovation in Maternal Health Reducing Preterm Disparities Safety Bundle. So all of those things that we're actually trying to institute and our review and guidelines around that were co-authored by Dr. Bryant.
So good afternoon, everybody. I am honored to try to close out this session that has been amazing. It is not an easy position to follow all these amazing and dynamic speakers. One thing I will say is that I am not in the least bit spontaneous. The notion of sort of spontaneously commenting on anyone's presentations was fearful to me, so I did present some slides that I will use today. But I think it's been a really powerful afternoon, and what I'd love to do is to maybe contextualize some of the things that we've heard and think about how we can think about them, things that each of you can do when you go home today and go back to your institutions, but also thinking sort of on the national and sort of even international scale. So as we've heard, really there's been a sort of an overweight perhaps of the maternal here, which I think has been really sort of appropriate. I have no financial disclosures. Those who know me know well that my one disclosure on every talk I give is that I'm a native New Yorker, so I talk real fast. So I have like 40 slides to get through in 15 minutes. I have no doubt that I'm going to do it. Also, I'm like hyped up on Sudafed, so I should be all set. This is my other disclosure from last night. So those of you who are my Facebook friends will know that this is our guinea pig that we've had for 17 days that fell on the floor and sustained a femoral fracture. If you see the x-ray, that's last night at 9 p.m. I was at Angel Memorial in Waltham, sort of, expediting now a transfer to the quaternary care Angel Memorial in Jamaica Plain for an open reduction fracture. People who know me from New York have said, you've been from New York City a long time when you allow a rodent into your home. And now I've done so much more. And the question is, how did that get to this place? And one of the things I would say is that motherhood changes you, right? So motherhood changes you. I've been blessed that motherhood has changed me for the better, but we've talked a lot about today about motherhood that has caused harm for women, and particularly women of color. So I'm going to talk a little bit about that. So also when I give talks, this is oftentimes the first slide of my talk. So this is an issue of the Boston Globe that was from 2002 that still sits in my office today. It's my personal kind of aha moment about disparities. So it sort of says, infant mortality of blacks on the rise. I was a chief resident at the time in the OBGYN program here, learning much about clinical care, and this very much resonated with me, but I knew that I wasn't going to hear much more about this in my maternal fetal medicine fellowship. And that was perhaps the inspiration for actually doing the Commonwealth Fund Fellowship as the second year of my MFM fellowship. Those who know me well as well will know that it was not that hard with my OCD and sort of, hoarding to find the exact USB drive on which was saved my practicum presentation 15 years ago. Thank you very much. And to May, 15 years ago, May 6, 2004, I presented on the impact of the Medicaid family planning waivers on racial disparities in pregnancy outcomes. And what I tried to convince the audience of in my background slide was that infant mortality was the proxy for the health of a community. That infant mortality really was the barometer for the health of the community. And what we've all learned today, I think, is that's really not the case. There's a new metric in town, and really how a community treats their women, how they treat their mothers, really says a lot more about the character of a community. And this for us really is our great national tragedy, and this is our great national embarrassment, these disparities that we've seen. I often have patients who say to me, they know I have two boys, they say, Dr. Bryant, are you gonna try for the girl? And every time I hear that, I think about this big orange bar, right? So this is 0.2% chance of death. That is me, right? African American woman over 40. I'm not naive enough to think that my sort of upper middle class or my education is gonna protect me from that statistic. And so that's what we've been talking about here today. We heard a little bit from Dr. DeClercq really about pregnancy-related causes, so hemorrhage, emboli, sepsis, but really that we should need to be thinking as well about the things that dwarf that, so the pregnancy-associated causes, because there are disparities in all of these, and we tend to talk much more about the disparities in pregnancy-related causes. This has been sort of echoed a lot in our own professional society, so in the maternal fetal medicine world, we really were going far left on the fetal side. So, you know, a lot of stuff on prenatal diagnosis, a lot of stuff on sort of growth restriction, and about 7 years ago, the society sort of reined it in and said we really need to put the M back in MFM. And so I think that on a national stage is where we are, and that's what we've heard a lot about as well today. I did sit on the ACOG Committee for Underserved Healthcare for Underserved Women, and so I had the pleasure of revising the committee opinion on racial and ethnic disparities in healthcare. And what we really wanted to highlight were those disparities that were egregious. We wanted to highlight those things that we didn't hear that much about. But in particular, what was important to me was to really talk to the provider about their role in terms of causing and perpetuating some of these disparities. So this is a rubric I tend to use from the American Journal of Public Health, and what I think is important is really talking about the role of the provider, talking about what we've heard today, the role of the place where the provider and the patient meet, the level of clinical encounter. What's missing from this, though, is the structural factors, right? So if we really played this to scale, the structural factors would dwarf out everything, but then you wouldn't see anything, so I put it in the corner. And so what we've heard today really are two distinct panels talking about changes that we can make within the context of the healthcare system, but also the things that we can change in the level of the community, and that pregnant women sort of float in between the two. But truly, if we think about it, pregnant women live much more of their time in their communities than they do in the healthcare system. So while we need to work together, we really need to be investing much more in the care and the attention that we're paying to community level interventions. You just heard that we were part of this effort to create a patient safety bundle around reduction of peripartum disparities. And this was something we were really quite proud of. So the Council for Maternal Safety and Maternal Health created a number of evidence-based bundles, and they really started with the big three, right? So hypertension, hemorrhage, VTE prophylaxis. And yet they elevated disparities as being an equal threat to maternal health as those other clinical conditions. And so our job is to try to create sort of actionable things that we could do to sort of reduce peripartum disparities. And you've heard a lot about these today, particularly from Dr. Molina, talking about things that we can do in the setting of the healthcare system. And so I just want to talk a little about some of those things that we do in our hospital that you could take back and do for yourselves. So we, as you heard, I created this topic. I said I would take this job of being the Vice Chair of Quality and Safety, but only if we could call it the Vice Chair of Quality, Equity, and Safety, right? So there is no quality care without equitable care, and we hammer that home with our providers. So our job is really to raise awareness of these inequities. So that's one of the things the bundle says that we need to do. This is a picture of my door. So just talking about our own statistics in our hospital, right? So African American women are more likely to be readmitted. We present that at every QA meeting that we have. We ask everyone to talk about the race, ethnicity, the language proficiency, and the insurance status of the patient every time they present at QA. So if someone's had an adverse outcome, you're presenting all of those things, and we should be thinking about how those things might have influenced the care that you received. Also, I just want everyone to sort of think about data collection. So we heard a lot from Dr. DeClercq about data this morning, or earlier this afternoon, and really the value of self-report. So I challenge you guys all to think about in your own institutions how this data comes to be. These are my children, who people might say are perhaps ethnically ambiguous, right? So if you're in the pediatrician's office and the front desk is assigning them a race ethnicity, how do we know that they are getting that right? And so I have multiple occasions tried to challenge the MGH registration line to see if they get it wrong, and they never get it wrong. They always ask me how I want this listed. They ask it first in an open-ended way, and then if I can't, they give me prompts. When I say that I want them listed as biracial, they ask me which I want to be listed first. Of course, I say African American, and they do it every single time. And so what I would challenge you, because I think that that is not happening across the country, and if we don't have adequate data collection, we are nowhere. So I'd say go back to your institutions and figure out how this is collected and see if you can make that as a change. We heard a lot about bias, so we have done our own sort of implicit bias training. We required all of our providers, all of our environmental health, nutrition services, everyone needed to do an unconscious bias training, anyone who touched patients in our department. We required our CNM and our MD providers to do an implicit association test, and we leveraged things like a quality incentive bonus to get it done, right? So people have limited amounts of time, but these are things that are important and can be incentivized. And then we continue those discussions in our workplace. So we had a race at town halls, and then we had the YWCA Boston come in to do a race dialogue training with our frontline staff as well as for leadership in our department. We heard about the pipeline, about workforce diversity. So this is my graduating class from 1998. That's me in the front over there. That's Hillary Clinton, 3 people down. She's the first person who called me doctor. Big sigh. Anyway, there were 36 black people in my class at Harvard Medical School, which is a feat that I do not think that HMS has repeated. But it's not always just about quantity, right? So we are our residency program as well is one that attracts a lot of underrepresented minority medical students. And what we've learned is that your experience in training is just as important as the number of people that are around you. And so we need to do a better job of taking care of the folks that we are training. And because certainly, you know, how we treat each other reflects how we treat our patients, right? So we can't think that we cannot be good to each other and yet also be good to our patients. We are also starting next month to collect microaggressions. So we're going to have an anonymous reporting system for all of our staff. We're thinking about heading out to our patients that they can sort of report the things that are happening to them on a daily basis that make their lives challenging to work at MGH. And then Rose and others have talked about advocacy. So there is a place. This is the time. This is the moment. These are our legislators who really are primed to hear much of this. So ACOG had its Congressional Leadership Conference a couple of weeks ago. Dr. Zara, Dr. Molina were there with Anna Presley, with Ed Markey in the hall. Everyone is engaged in these topics. And the asks this year really were around maternal mortality, around some of the bills that you've heard before. Moving beyond 1318, which is just the authorization of maternal mortality committees, but really thinking about how we can fund the PQCs, how can we fund AIM? How can we do implicit bias training? How can we incentivize those things at a national level? You heard from Dr. Grant a little bit about the challenges of hypertension in one hospital. We need to scale some of this work up. So this is from the Illinois Perinatal Quality Collaborative, where they, over time, once you can leverage the power of a number of hospitals, rural, and community hospitals, academic medical centers, everyone gets on calls and does work together in this collaborative way. They have shown a marked increase in the number of women who are treated adequately in a short time frame for hypertension. Same thing in terms of the number of women who are given patient education materials when they go home, and that over time their rates of severe maternal morbidity have gone down, and so this really works. We talked a bit about the maternal mortality review committees. I have the pleasure of serving on that committee. What I love about that committee is we really dig down deep into each patient, but what I think that the Lost Mothers series really did for us was to show us the women, show us their names. You could click on any one of these and get to people's GoFundMe page or their obituaries. We cloaked the MMRCs in a little bit of cloak of secrecy, right? We're not supposed to say the name, we're not supposed to say the provider, and yet if we're working in through the lens of just culture, where everyone who showed up to take care of these patients were showing up to do their best, why can't we sort of lift that up and really learn who these people are? I'm going to breeze through this very quickly, but we heard a little about levels of maternal care. I think this is going to be important in terms of keeping women safe, but we've got to include the community in this, right? So if we are finding that particularly African American women who are supposed to go to the level 4 center are not making it there, we need to use some qualitative work. We need to talk to women about what are the barriers to getting where they need to go, as opposed to this sort of top-down notion of you go to hospital A and you go to hospital B. This is from the New York Times. It said, why Americans' black mothers and babies are in life or death crisis. The answer to disparity in death has everything to do with the lived experience of being a black woman in America. What I think has been powerful today is about hearing people's stories. We keep hearing how black women are not listened to, and we have heard really some powerful narratives, and that needs to be a great part of this work. Racism, not race, we heard a little bit about this toward the very end, is that we need to stop saying that race is a risk factor. Really the risk factor is racism. And so this quote comes from Jessica Roach, who has a doula organization in Columbus, Ohio. So this idea that the perception of black families related to constructs such as poverty, education, housing instability, and race and health as a risk factor continues to validate the so-called social determinants of health rather than address the structural and institutional policies that have created them and therefore the consequences of their impact. This is her web of causation, which looks a lot like the slide that I showed you, but really contextualized in the things that cause all of those things, right? So slavery, Jim Crow, the GI Bill, redlining, the 13th Amendment. None of these things exist without these historical contexts of racism, and so we really need to speak that name. This concept of reproductive justice will come up a couple of times. So Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So you heard a bunch about that in sort of the community panel and how we need to empower women to speak for themselves, to say what they want and how we can help them to get there. And then lastly, just I think to bring it back to this notion of infant mortality that we started with, we can make change, right? So we heard that in Boston we are making change in terms of the decline in the Black infant mortality rate. So how did we do that? What was new, they said in the Boston Public Health Commission, was an explicit focus on the impact of poverty, racism, associated stress on health, and that was really sort of very much impactful. And so can we apply that same lens to our thinking about maternal health and well-being? And lastly, I would just say we need to strike while the iron is hot, right? Everybody's hot to trot on this. Elizabeth Warren's got a bill. Kamala Harris has got a bill. This you heard yesterday came out in the New York Times. We're like, I really guess we knew this, but this was really about Emily Peterson's work that you heard about from Jean DeClercq about pregnancy-related deaths and the preventability of them. And so this is like the first time that all of these organizations and many, many more that are not on this slide are all coming together. So community-based, grassroots organizations, professional societies, all aligned in a similar way, and so we really need to move this needle. And so I thank you so much. I thank you guys for listening for the panel today. And lastly, I wish everybody a happy and a safe Mother's Day, and hopefully we can sort of keep everyone safe in this context of motherhood and have motherhood change them for the better. Thank you.
I want to say thank you to everyone, starting with Dr. DeClercq, our panelists, our moderators, our commentators, and you, the audience, for staying engaged and participating in this conversation. This was a really powerful discussion, and I love to hear, I love just all the comments that I was hearing and the dialogue that was happening back and forth between the audience and our presenters. And I think this is a great opportunity for us to continue to be engaged in this discussion, to lead in this discussion, to make policy in this discussion, and to see the changes we'd like to see in our communities going forward. With that, we will be ending for the day. Just a couple quick notes. There's a Reed Scholars Business meeting at the T-MECA building across the street starting at 4:15. And it's at room L008. For all of the Commonwealth Fund alumni, OBGYNs, we'd love to get a picture of you as part of the process for today. So Jeff, where would you like everybody? Come on right up towards the front for our picture. We will be starting, I believe, at 9:30 tomorrow morning for our next component of the annual meeting, so we look forward to seeing you all bright and early tomorrow morning at 9:30. And again, thank you for your time and thank you for your attention.